and welcome here live from Madrid at the second day of the 26th annual scientific meeting of EAO, the European Association for Osseointegration, which is a joint meeting this year together with CEPES, the Spanish Association for Prosthodontics. Welcome, and we're glad you're joining us again, because for the next 2 hours, we're going to learn all about the evolution of prosthodontics in the last 25 years and where it might be heading for the next 25 years. And specifically, we're going to zoom in on the difference between the conventional methods and the digital methods. Now, this is what we call Online Congress. And what's going to happen is we're here in the middle of the exhibition floor, actually in the middle of the digital village, where the delegates just got out of a scientific session and are going for a coffee break. But for you, as our online viewers, we're going to fill this coffee break with a preview. And I'm not going to do that alone. I'm very proud and honored to be joined by two really experts in the field of implant dentistry. Ali Tamaseb from Amsterdam in the Netherlands, and Vincent Famer, you're from Geneva in Switzerland. Guys, welcome, good morning.
Thank you, good morning.
Now, for our audience members who don't know you this well, I cannot imagine there's anybody who doesn't, but could you briefly introduce yourself?
Yes, thank you for the invitation. My name is Ali Tamaseb. I work in Amsterdam, as you mentioned. I did my dental school in Ghent, Belgium, back in the 90s, and then I moved forwards to United States, stayed there for like 6-7 years, and I did my implant and perio program, and then came back to Amsterdam and to Europe, to Amsterdam. I did my PhD, and since then I'm working in the university as a professor.
Exactly. Well, welcome, and thanks for joining us.
Thank you.
Vincent?
Absolutely, same here. Thank you very much for having me. I started my training as a dental technician in the south of Germany, in Stuttgart, and then I moved on to do my master degree in Berlin. Did some years of training, went to the US, to the UK actually, before I finally moved to Switzerland, first of all to the University of Zurich. And 3 years ago, I moved on to the University of Geneva, where we really dedicate quite a bit of time to the digital field. So
exactly, you're a specialist in the topic we're going to look at.
Let's hope.
And let's make people understand what your role is here, because first of all, in the next 20 minutes or so, we're going to preview to the session and kind of explore the topic and the dilemma here. But later, after we've watched the session, we're going to actually pull in the speakers into this little studio and do a speakers debrief. And you guys are actually going to help me to kind of reflect on what we've heard. And together with you as an online audience, you can use the fact that we're live on Facebook to type in any questions during the broadcast. If you do that during the session on stage, the moderator on stage will actually receive your questions on his iPad. And if you do that during the debrief here in the studio, I will take your questions on your behalf and we'll make it a nice live interactive bit. Before we go deeper into that, we want to have a quick look back at what we did yesterday, because yesterday was the first episode of Online Congress. If you were there with us already, thank you very much for all the love and sharing. It went crazy. If you've missed that session, there's two things you can do. First of all, the session is still available on the EAO website and on the EAO online library. It's also here on the EAO Facebook page. But to make life easy for you, we also created a little summary of the key message of yesterday's session about regenerative bone protocols.
I think that pre-prosthetic surgery in the current days should be characterized by what I call the pure strategy, which means that we basically need to, of course, preserve.
How did you like the session?
Very much. Amazing. It just makes you want to be a much better dentist than we are.
However, things have changed, and guided bone regeneration started to be applied to this type of defects. And this is a young patient, and this patient has a car accident. So we have patients with accidents. We have patients with dental failures. We have patients with peri-implantitis, and they're young, and they require for regeneration.
So you're from India. Is there anything that you're taking from this session you're taking back home?
Yes. One thing is a lot of concepts have become clear, especially on some of consensus reports on how bone grafting and how does it help, especially in vertical and horizontal ridge augmentations. Also, we saw in the first session how it has evolved, how we were doing surgeries before and how it has become much better these days with immediate loading of implants. So a lot of learning.
So at the end, we cannot, since there is not a lot of evidence on which method is best, we cannot fall or end in a paralysis by analysis. So we need to mix the existing evidence with our own experience and the experience of our peers and companions, and with our skills.
I like it very much. I think it was super interesting because they talk about topics that we need to know about. We need more research about the topics.
What topic in particular?
I was especially interested about GBR because when there is such big defect in one patient, I didn't know actually that you can do that kind of big regenerations only by GBR. So I found that one really interesting.
And this is not a duck hunting accident. These are titanium pins reconstructing the maxilla with gaudy bone regeneration. And this is the reconstructed maxilla. And this patient did not need any blocks, did not need any extraoral harvest. Just use membranes and some scraped bones.
We especially like the latest session from Professor Urban. And basically, this is one great event.
Which is the most important and most complicated part of this soft tissue management. It's the most important part, which, by the way, needs to be done at the beginning, right at the beginning of the procedure. Because it normally bleeds when you make scoring of the periosteum and you make muscle dissection, which you need to do sometimes, even to delete. It bleeds a lot. So
the last session was fantastic. Two great lecturers. They're artists. Stefan Urban was beautiful work.
I start to remove, and we always find in a low-grade situation an area which was uninfected yet. So, as you can see here, with this treatment, we can get a patient, take a patient from here to there, even in a event of a complication.
Anything that you say, okay, I want to try that, I want to do that myself?
Not yet. I'm so young, but I hope I will do it.
And the good thing about these sandwich techniques is that it's like a biological box, and you have bone in and out in the split techniques and up and down in this kind of procedure. So you tend to think that having vascularized bone all around will improve the quality of the bone that it is formed.
Anything you've learned that you say, okay, I'm going to do that?
Yes, I'm definitely going to, I think, I'm going to visit Stefan Urban in his office. So I'm going to do my check-in online.
And that's a sneak preview of what you've missed yesterday and what you can actually still access on the Facebook page and on the online library. And I think it's important to explain that during this Congress, a lot of professionals from the implant dentistry world are gathered. We have over 4,000 people here from over 66 countries. Obviously, that's wonderful, that's great, and all the content is being presented here on stage, but there's a lot of cameras in these rooms as well, and a lot of content is being captured, and that is made available to you, to anyone in the world, through the EAO online library. Now, the good news is that is normally a members-only accessible resource, but today, and for the next 3 days until Monday, this online library is open to anyone. So if you want to explore and want to see what one of these benefits actually is, you should go to the EAO website, click on the online library link, and then create a temporary access account. And you can explore all the abstracts, the posters, and also videos like the one you've just seen before. Now, over 4,000 people, 66 countries. We took our cameras into the stream of people early yesterday and asked them, what do they expect of this Congress?
I'm from Denmark.
You came a long way to be here.
Yes, a fairly long way.
I come from China.
So you came a very long way to see this exhibition?
Maybe 20 hours. Yeah.
We are here a group of around 10 people coming from Jordan to attend this big event here in Spain. I think this is a very prestigious and very important scientific event in the field of implantology in the whole world, and it's well known. And we are very happy to be here in Madrid for the first time to attend this Congress.
When you get back to Brazil, what do you hope to bring back?
Well, some news and a new energy for the work, and that's it.
We're good in Brazil. We have great technology, great specialists, great teachers, great professors. We're really good, but it's always good to see other opinions.
To get better?
Yes, that's it.
Do you think you're going to see the future of your profession here?
Yes, and I think the theme around the Congress here regarding the digital implant dentistry is going, and perhaps it's even for our countries in the Middle East, we are exploring the future for the coming future in trends in digital dentistry, and hoping that we can see this live here in the exhibition and in the lecture room.
I think it's one of the most important event in dentistry in Spain, and I'm proud for being in Madrid.
Very important, yeah, because here we meet all dentists, special dentists from all over the world.
Technology is changing very fast.
Yes, it's true. It's really amazing. I mean, it's incredible what we are doing now, and how we can do the things now with passions. I mean, it's amazing. Yes.
Hello and welcome back here in our little studio. If you just joined us, you saw us interviewing all these delegates, over 4,000 delegates from all these countries. But obviously, you are now with us live online. And we're really live, so I would love to practice a bit with this interactive bit with you. If you're watching right now, give us a comment right now who you are and where you're watching from. For example, the team from Straumann already did this in the first minute. Great initiative, Straumann loves it. Well, if you want to be world famous and you want me to do a shout out to you, this is the time to give us a little comment. And if we get that going, that is also the way how you can interact with us right here in the studio and also with the speakers on stage. Just type a comment and we can read them out, use them, and for example, I could ask questions on your behalf to my two experts. If you're just joining us, I'm here with Ali Tamasep from Amsterdam and Vincent Famer from Geneva. And you are here as experts in the field of implant dentistry. And let's have a look forward to the session we're about to see. Title is Evolution of Implant Prosthodontics. It's one of the three main sessions of the Congress. It's a big plenary, 3.5 people joining in the big theater. And we're going to see two speakers. Stefan Wolfart talking about is conventional still future oriented? And Ricardo Mitrani about is digital the new conventional? Now, start from the broadest area, digital conventional. What are we talking about here?
Well, I think we are talking about the evolution that we cannot stop. If you go to the meetings, you go to the expos, dental expos, I mean, you cannot look around and not seeing anything in the direction of digital. Actually, I think that complete analog or conventional, it cannot be done anymore.
Okay.
I mean, if you look at the schools, dental schools or dental technician schools, they're almost, all of them are pushing and getting pushed towards the digital dentistry. So I think it's good that we have the comparison between the two, but I'm sure that both speakers, even the conventional one, wouldn't do anything completely conventional. And is the digital the new conventional? I think yes. I think when I was a student back in 90s, the most digital thing I had was my watch.
Exactly.
Other things were all analog. And a few years later, when I came out of school, for example, the digital radiography came out, we didn't really believe that it's going to take over everything. And now you cannot even buy an analog radiograph. So everything is digital. And I'm pretty sure in a few years, we don't even talk about a complete analog workflow in the dentistry.
Exactly, because we talk about digital in different steps in the process, right, Vincent?
Exactly.
Because you now mentioned imaging. Is there, where are we in terms of a 100% digital workflow, and which steps are still traditionally conventional?
I think this is the tricky question in the end, because you realize why, if Ali, and I 100% agree with you, besides the watches, that shouldn't be digital.
No, exactly.
You have to.
You have a beautiful watch.
No, so that is completely the analog way. But what is clear, how come that this is a topic in the main session in a big congress if everything is digital? Clear. we are digital and we try to push it on the schools on behalf of the industry. Everybody wants to go with the technology because it really allows us to do new things, offer the patients more, what we were not able to offer them before. But the problem is at the moment we have like digital islands. You can maybe imagine it in a very easy way. So the islands are still not connected with nice, broad, wide bridges. So there's the small like gaps in between that are still a hassle to our treatment like routine. And this is the reason for sessions like today, to really understand what can we achieve by going from A to Z digital and where is the limitation. So where is still the need for the bridge, and the bridge is in these days, to our understanding, still an analog way. So there is the balance.
Yeah. Let's explore that a little bit deeper. First of all, what is the risk of these digital islands? What kind of new challenges do they bring to us?
Well, I think one of the biggest risks today is that some of those products, in my opinion, are not ready. And the urge of commercialization and finance sometimes push some companies to put things on the market, which can also destroy, the background and then reliability of these things. And because we know, especially when you're in an academic setting, you know that there are a lot of shortcomings, as Vincent mentioned, not only those connection with those islands, but also the islands themselves, they have to get much more improvement. And I think the biggest risk, as a clinician, is first, you have no idea which way you have to go. You buy something today and you realize the next day is already gone and then old.
Because is that happening in this industry as well?
It is happening. Yes, it is happening. The development is very fast, and I think the question I get a lot from people when they come to courses and participants is, should I step in now
or wait?
And the answer is very difficult to give, because if you don't step in now, so maybe you miss the train a little bit. And if you step in now, then you have maybe, the things that you're buying and paying a lot of money for that is already old next day, or maybe the same day. So I think there are a lot of shortcomings.
So what do you often answer to them if they ask you?
The answer I just gave you. It depends on you. Do you really want to be in the development? You want to be, part of it? Then you have to step in. Frontrunner, you have to step in. It's going to cost you money, and you have to repeat that maybe the next day. Yes, I think so. Yeah. You have to understand that. So I think that's the biggest challenge.
There's like shortcomings to everything new. That's pretty clear. And people, in a way, anticipate by having these new tools that they buy. It's like a new car. You just put your key to it, you start, and it just works. But you have to implement it to your office. You have to implement it to your settings.
Exactly.
So what is the best advice to those people is just bring it into your office, give it a try, understand how this system works with your daily routine, and then you see how it evolves. You give it some learning curve. Yeah. But to understand that 20 years of conventional training is outdated in 1 year or 1 day of training digital, it will not work like that.
So that's the first key takeaway that you advise to our audience. Yes, you have to step on the train, but you have to be aware this is an investment in time and finance and workflow and all the hassle that comes with that. Now, if we try to make that small, because we're still brilliant, you have to step in somewhere. Is there a way to prioritize? What are the easy steps to start digitalizing your workflow?
I guess the easiest is the digital camera, which is for us a daily routine since we have the mobile phones. So that would be the first step, but you have the direct control of the pictures, of your try-ins. You can communicate with your patients. You can do small movies. This is the first thing. Then the next step is any kind of three-dimensional diagnostics, which in a way is an expensive step, but it has a big value and also brings value in return for your offices. I would say, if I may continue on the lab side, the step is really to have a milling machine. So that is the important part, and have a design tool so that you can handle data from whatever direction that they come. This is, I think, the steps that you really have to consider, especially if you think of the efficiency chains.
Exactly. So you start with imaging, modeling, and milling. So that whole first part, it speeds up and it's easier.
Yes. I think also what's important, you already mentioned, is changing the mindset, because I think that's the biggest challenge. When you're a bit older dentist, older colleagues, and you have to get pushed from the analog is what you used to work. You get pushed towards to digital one. You have to really prepare these people, and you cannot just push them.
Yeah.
And that's the people, because I only work on the surgical part, which means that all the preparation is supposed to be done by my referring dentist, or the prosthodontist.
Yeah.
And we struggle a lot when I work with older colleagues. I don't really get the information that I really need to have. And this information, especially the surgical part, is now maybe the most advanced part in digital dentistry that is already out there. I mean, you can really use that. It's not so expensive. It's just really, you don't need, milling machines or scannings or whatever. You can really do it online. You can have your images done somewhere else and put it on the cloud and send it to me. And that helps a lot. But the biggest struggle I see in these people is that they're not used to it.
Okay.
And the mindset, the changing the mindset, I think would be the first step for everybody to go to digital.
And I guess you're touching on an important topic in a setting of a congress like this, which is bringing together a community.
Exactly.
This is about bringing it together, the community, in this case around the patient.
Yeah.
So from a surgical perspective, or from the perspective of a surgeon, what can you do to actually take these dentists, you're referring dentists along? Do you take initiative in this?
Yes, what I do, for example, in my office is I try to be in really close connection with these people, with my referring dentists, in a good, dialogue. And we also organize like meetings, smaller meetings that you can really talk one-on-one and try to, show them that it's not so difficult. We can help you. Because you can also take everything out of their hands. You can say, what, you just send a patient and I do that. But it's not the purpose. It's not the purpose of, working together. Also for these people, it's nice and it's fun to be participant of the whole treatment. So what I'm doing is, I'm trying to use the things I have. And I have to say the companies that we work with, they're also helping us a lot by organizing smaller courses, smaller events, national stuff. This is, of course, fantastic, but not everybody comes to Madrid. It takes like a few days of our office, and you have to leave the home. But I think smaller initiatives and go local is very important, and talk to them one-on-one. That would be, I think, the best way to teach them.
Vincent, what experience do you have or examples do you see of connecting the fields with each other?
I think if you just refer to Ali's topic, like really interacting with your referring dentist, there you have the biggest tools on hand already today, ready to use, perfectly digital, no island, it just works. So this is amazing skills where you can really translate and transmit all the necessary information that you initially planned, that you want to have Ali to execute, and thereby to understand that once you receive the patient back to your office, everything is the way you initially planned it. And not, the old way, the conventional way is always you take the phone, you talk to each other, and you define, I want to have an implant in this position.
Very conventional. Very conventional, right? Just pick up the phone and talk to each other.
So this is still an important thing because you have to have the feeling, the tone for each other. And I think it will always stay like this. But in addition, now you're sitting in front of a computer, like just you're standing here, and you will see the picture of the patient in the same screen. You're looking exactly at the same information. So the communication level, the safety of your treatment, all of this, steps up with the digital environment.
Nice. If you're just joining us, let me explain what we're doing. In about 5 minutes, we're going live into the room where we're going to see the main session number 2 of this Congress here in Madrid, which is all about the evolution of prosthodontics and mainly conventional versus digital. And we're live with our 2 experts and some people online. I want to say hi to the team of Straumann because they actually sent in a question. So this is lead by example. If you're live, you can react to us. And the team of Straumann is asking, in your opinion, how will digital technology enable the dental professional to make the patient part of the whole journey? For example, consultation via Skype, predicting treatment outcome with augmented reality, aftercare, and so on and so. So we just talked a bit about integrating the chain of the medical professionals from surgeon to dentist. How are we going to include the patient in it? What's your view in it?
Well, I think this is already happening. I mean, the software and the tools that Vincent just mentioned is a great diagnostic and communication tool. I mean, the picture on your screen, on your computer says 10,000 more than things that we try to explain.
Yeah.
And, and everybody has internet, everybody go online. My patients, when they come to my office, already they are completely informed about what I'm about to do, sometimes misinformed.
Exactly.
And
Dr. Google.
Dr. Google, exactly. Dr. Google said totally different what you said. Most of the time I said, just go back to Dr. Google.
Yeah, exactly.
But, But when we use those softwares and those planning softwares, it's something that, as Vincent mentioned, it's not only between me and my patient, it's not only between me and my prosthodontist, but also between me, prosthodontist, the dental technician, but the patient also. And that's a great communication tool. I mean, we already used it. We already use that. Yeah.
And in your experience, Vincent, patients, Skype consultations, any experience with that?
I don't think that there's still a need. If you want to have a perfect aesthetic, it would be great to be on site at some point to meet and to feel the patient.
Yeah.
But on the other hand, to give something along to the patient, the patient don't care for an implant. The patient doesn't care for a crown. The patient wants to close the hole that is actually there. So in understanding for the need of closing the hole, you have to give informations and you have to give them a chance to visualize it. And what is clear for us being a professional, how we might solve it for the patient, it's not because it's not like buying a new jacket. We can go to the store, we can try A, B, and C, and we decide for A. But here we have to explain them. And the digital process, once again, helps a lot in visualizing. So this is great.
And I think then you're touching, because I noticed we're celebrating digital all over and the future is so bright, yet we're about to go into a session where we also debate whether there's some conventional things that we need to cherish.
Oh, yes.
Face-to-face contact with patient is one.
Yes.
What are the other big benefits of some conventional steps?
The skill stays. I mean, even if you have somebody who hold your hand, which is the digital thing should do, you still have to have skills, you have to have your experience, and you get better every day. And I have to say, you need to have guys like Vincent. I mean, whatever digital it trends, that personalized touch of the dental technician, I do not believe that is ever going to change. I mean, they might have other instruments to do that. They got maybe digital instruments to help that. But you have to consider the dentistry is also a bit kind of art. For us, we see ourselves sometimes as an artist, and I know the artists also use digital stuff. I went to the exhibition in Paris of David Hockney, and I saw his new paintings were done on iPad.
Yeah.
But he did that. Hockney was playing, working with him, and I think that's not going to change. That part of the conventional, as you mentioned, I think it will always stay.
Yeah.
And at some point, besides all the visualization, you can, with using augmented reality, you can show patients more bright teeth, longer teeth, shorter teeth, whatever they desire. But at some point, they have to have a chance to speak with those teeth. Not only once this is the final cemented or screw-retained reconstruction, you see. So the point is to give them a chance at an early stage in the treatment phase to make them feel.
Yeah.
To make them chew, to make them speak, laugh, certain sounds, count, all of this. So once again, maybe you can produce this kind of try-in, mock-up, diagnostic aspects. You can maybe mill them, you can print them. But finally, it has to be physical.
Yeah.
It has to be in the reality. The patient has to have it inside his mouth and function, speak. So here we are back again in the island, in between, having to have the patient as our reality.
And in that sense, we can be confident that our jobs as implant dentistry are not going to be replaced by robots or digital.
Not to worry.
It's still an art and a trade.
That's the instrument. Digital stuff is an instrument and has to be in the hand of the surgeon or dental technician. That's the instrument.
All these factors. But you just know that in China, the first implant was given to a patient
by a robot.
Yes. So that is daunting in the future.
Yeah.
Now, this is where you hear the latest news. We just got a scoop. Maybe we talk about it a little bit more when we come back from the session.
Good morning, ladies and gentlemen. Welcome back to this second session of this morning. We are very excited to be able to participate this session together with you. My name is Irena, and together with Jörg Strub, we will moderate this morning's second morning part, which will be more focusing on prosthodontics. I think it's an exciting topic. Isn't it, Jörg? It is digital dentistry versus conventional dentistry.
Yeah, and because the patients are coming because they wanted to have the teeth back, they don't want to have implants placed. That's a major issue.
Maybe, possibly.
Right.
Well, you might have noticed that during these conferences, several sessions focus on this topic. So it seems to be something that, although it's there since many years, it's still not fully clear. And that's why we have invited two renowned experts in the field. First of all, we'd like to invite on stage as the first speaker, Mr. Professor Stefan Wolfart, who is the head of prosthodontics and biomaterials at the University of Aachen. So welcome, Stefan, on stage. And as a second speaker?
The second speaker is Dr. Ricardo Mitrani from Mexico City. Please also give him a very warm welcome. For him, it's like being at home here.
So what we can say now, we have these two experts, and the one is a university professor. He's in a university environment. He has all the science behind him and maybe all the time in the world to pursue the treatments, which is different for Ricardo Mitrani,
who is working in the private practice environment. By the way, Irena, we have also to welcome the online community. Yes. Because we have only 3 sessions that will be running this way, and we are in the second session. That's important that they can follow us too.
Yeah, we're very happy to have you here, wherever you are. Follow us on Facebook, and thank you very much for being part of this session. So we've invited these two speakers now to discuss several topics with them, which we felt were of clinical relevance in the field of digital versus conventional prosthodontics on implant. And as I said, we have 2 different settings. We have a private clinic which has to run, which has to produce, and then we have a university setting where maybe you have more time to do science. So first of all, I'd like to ask you, Stefan, as an expert in prosthodontics, and you've also written a textbook on it just recently, how would you approach a fixed prosthodontic case in your department when it comes to complex solutions?
I think you have to go back.
Okay. Thanks a lot, Irena and Jörg, for this very kind introduction. And first of all, I want to say hello to all of you. And it's very nice for me to speak here in Madrid. And it's the first time for me that I'm here. It's a beautiful city. And yes, I'm really love it to speak about this topic together with you. So before we can start with my case, I want to focus you a little bit on which work steps we have to focus when we think about conventional versus digital. There is the dentist workflow, which is the surgical guide, the provisional restoration, the impression taking, and the relationship record. And we have the dental technician part, which is the articulation, the setup, the framework, the veneering. And we have to look at all of these single work steps when we really want to talk about conventional versus digital. And I want to share with you this very nice old lady which came to my office, and she said to me, I know I will lose all my upper teeth. I'm nearly 70 years now. However, I don't want to live with a removable partial denture. And it was like she said she lose all her teeth because we could not keep one of them. And what I'm doing is I start with a setup. I try in the setup, I transfer the setup to a radiographic template, and this with a CT-BD scan, we bring to a surgical guide, position the implants in the right position, and with special drills, we can bring the implants in the perfect position in combination with the sinus augmentation. And so we have implanted the implants in the position where we want to have them. Then we came to the impression taking technique, and that's something which I do conventionally in these cases. I have a customized impression tray, I have a polyester impression, and I get back from the lab a cast. Then we came to the maxillomandibular relationship record, and we are doing that very carefully. And this is the beginning of the 2 setup, and we try in the 2 setup, and we can check the vertical height with this 2 setup. We can check the transition between red and white aesthetic. We can check the phonetic things, and all these steps we can check now. So this is the beginning of the framework design. And when we came to the framework design, then we realized that the angulation of the implants and the angulation of the screw access hole is a little bit different. And so we need special screwdrivers which have a rounded head with special screws to solve this problem. But in this case, we really need a digital framework design because so we can construct these angulated screw holes. And as you can see here on this slide, you see we have enough space here for the veneering afterwards. So it was a perfect design of the framework to go further. Here you see the fit of the framework on the cast. It's perfect. And then we have to look at the fit also in the mouth. That's clear. But with this step, we combine it with a two setup again to know where the transition from red to white aesthetic has to be in the end. And now we go with this information, we go back to the lab and we make a veneering process, a normal standard veneering process. And we go back to the clinic and try in the restoration, make a registration recheck, go back to the article later so that we don't have to, so that we don't have any problems with occlusion in the afterwards. And then we can screw in the restoration. That's very simple. We clean the implants. The emergence profile is already formed. We put some chlorhexidine gel into the implants, take the restoration, put it into the mouth. And the problem is a little bit with these screws because they are a little bit loose on the screwdriver. So we use some chlorhexidine gel to fix it. And then we go in and screw it in. So here you see the final results after 3 months, and here the old lady after 1 year of wearing this prosthesis. So if we summarize this on this checkpoint list, then I have only 2 things which I have done digital. That was surgical guide and framework. All the other things were done conventional.
Okay, now, Ricardo, would you please say a few words in Spanish, because it's almost your hometown here. And after that, would you tell us how you would approach a case like this, please?
Sure. Buenos días, Madrid. ¿Cuántos hablan español aquí? Okay, 50%. Cool. I'm going to switch to English now. And it's a pleasure to be back and see so many friends and family almost. As Irena and Jörg pointed out, my take is a bit different than Stefan's because I'm going to come from a clinical, private practice perspective. So we run 3 practices back home, and I'm representing a very solid team of clinicians and technicians today. And so what I want to do is basically share with you some of our experiences in dealing with these type of patients. So in order to keep with this thought-provoking mode, if you will, let's start with our first patient. So Manuel comes with a severe problem, as you can see in these pictures. Pretty advanced periodontal disease. And if you consider helping him out and doing conventional approach in order to start planning the case, just as Stefan showed, any impression, even with the most soft impression materials, would mean multiple extractions. These teeth are just held up basically by a mesh of tartar. So in fairness, it's almost impossible to go ahead and make an impression, not extract these teeth. And if we were to do that, that right there would set us to a couple of appointments to get our planning to where we want it. So when a patient like this, today, with what we have, it's relatively straightforward and simple to go ahead and do some intraoral scanning. This is not working. Avoid conventional impressions. Before I go there, though, as far as our restorative design and having a discussion with the patient, and we'll talk about this further on today, but we have 3 choices for these types of patients. So for Manuel, we're going to go for a fixed hybrid approach in both arches, right? And so now that we know what we're going to do, the easiest way is to go ahead, scan him with an intraoral scanner, and then start figuring out where the teeth belong in his face. Now, as you can see, without all that mobility, doing a jaw relation record is next to impossible. And so we're basically guesstimating so many pieces of the puzzle here in order to provide some type of sense in the planning and ultimately provide a provisional restoration. And so basically we use, the extraoral parameters to figure out where we believe the teeth should fit in the patient's face. And once we have figured out where we want the maxilla, we then go to the mandible. And you can see the offset that we have from where the actual teeth are in his mouth to where we're now planning the new position in the mouth. And so from that, we're now readily able to print not only all our multi-step approach into the extraction, bone reduction guide, implant placement, but also we're printing provisional restorations for him. And so you got to think about this. We saw this patient once. Second appointment, we're ready to go basically to this multi-step approach and provide a solution that right there speeds up the whole process. Oops. This is crazy. It didn't go so fast in the clinic. So we're ready to go, and this is the surgical procedure carried by two of our team members back home. And if you can see here, this type of devices, they are all going to be fixated via guide pins. And so it's fundamental that you utilize the first positioning guide that ensures the pathway for all the different devices. So once we have that first positioning guide in place, it's relatively then straightforward to move on to the next steps. So we make the extractions, then we go to a bone reduction phase, then we go for a third phase, which is placing the implants. And of course, we start with the maxilla. We do our reline of the provisional, and as you can see, the provisional also has these same guided pins that fixate the maxilla. So once we're done with the maxilla, we move along and we do the mandible. And once we have that, we're doing the pickup of both provisionals. So basically what this means is that now we go back to the lab, we trim the sprues, if you will, that have the guide pin sleeves, and just fine-tune the intaglio surfaces of both arches. And we are now ready to deliver these type of immediate provisionals. And so we just fine-tune the surfaces in which we remove those sprues that I spoke about. And now we have both arches ready to go. As I said, now this is going to be a hybrid design for both arches. And the nice thing about this approach, again, is that it pretty much fast forwards the case. This is the second time around that we see the patient, and we're putting him at a point in which it's very smoothly to move on to the next stages. Now, as you'll see, the teeth in his face are pretty acceptable. We still need to fine-tune the position here and there, but it is highly workable. So since there's going to be a hybrid design in the end, we will be able to modify at some point the ultimate position. And typically what we do with these patients is that we show them the actual picture and we hesitate for a second to remind him how he walked into the office the day before, because typically patients forget, don't they? So with that in mind, I'm going to pass it back to you guys and start a discussion.
Well, you've seen totally different approaches to two sort of similar patient situations. And the ultimate goal is that we have a very predictable treatment steps and that we have a very predictable treatment outcome and in the end satisfied patients and good longevity of the restorations. So we were thinking when we saw these two cases, why were the approaches different and why should we approach patient cases digital? So why digital at all? Why is it a question at several sessions only at one meeting like this one? Then when conventional, when digital, then how can we integrate all these different workflows in the practices, in the clinics, in the university? And finally, what are the consequences for oral view out there in daily clinical practice? So we would like to advance now with the first question and maybe go back to Stefan. And why digital? Why not conventional, as you showed in your initial case? So what out of your mind are the reasons why everything is turning digital at the moment?
Ricardo, you showed me that you do everything digital, but I think we have to stay with some of the things also conventional. And for me, I'm coming out of the conventional world, and so I need to have criteria when I should change from conventional to digital. And for me, the criteria are, we need clinical studies who show that these results, which we get digital, have a quality improvement, better patient comfort, economic improvement, and will simplify and faster treatment. When these criteria are fulfilled, I change from conventional to digital. And I want to show you on 2 examples that this is not the way in the moment. For example, for impression taking for complex cases in the edentulous case, what you have seen before. So this study by Armin and co-worker, he had a stone master cast, and they made a conventional impression and an intraoral scan and compare the results. So it's very easy to understand that in his study, the full arch digital impression were significantly more accurate. That was something which I could not believe in the beginning. So it was, the error for the conventional was 160 microns and for the digital only 46 microns. Mm-hmm. However, there are also more critical studies. For example, this study, they have also had a master model with 6 different implants in, and they showed that the error which we have when we scan the first quadrant with a CEREC system is around 17 microns, so it's very, very precise. However, if we go for full arch, then the error gets bigger to 160 microns. And this may be because of the area where we have no teeth, that this makes the scanner a little bit more inaccurate. So to conclude this, in the end, we have no clinical studies for that. And the transferability from the in vitro studies is possible, but we have to do it with caution because of the movement of the gingiva, which may in vivo increase the scan error. So for me, I will stay with these big restorations with a conventional impression. Let's go to the maxillomandibular relationship record, to the articulation and to the setup. There's a review by Zimmermann, and they conclude that the limit is the complete loss of occlusal support. So if you have no occlusal support anymore, you should not go digital with the registration. And you cannot make a registration recheck, which I showed you is very important, so that you don't have to make too much occlusal adjustments. Thank you. And if you see this for the simulation of dynamic occlusion, it looks beautiful. And you see the context, you see like the contacts are moving, but we have no scientific data if this is also the reality. So first I want to have the science, and then I will change my, my office. So, and then something which is very strange, that we make something digital, and when we want to have a veneering afterwards, then we go back to an articulator with printed models, as you see here. And the first possibility is this clip-clap articulator, which you can see here. And I think this means going 100 years back in history of dentistry if we use this system. The second possibility, which I would prefer, is this situation where you have 3 pillars, and they key the registration of the digital world, and you have to go back now with a face bow into the normal articulator and the conventional articulator to start with the veneering process afterwards. Mm-hmm. If we go to bite registration and 2 setup, then the conventional situation gives us so many advantages. It's easy to check the vertical height by phonetic tests. It's easy to check the visibility of pink and white aesthetic. It's easy to check the lip support. If you go digital on a face scan or something, it's very complicated, and you don't have these things directly. So it's not predictable digitally in my world in the moment.
Okay, I think now it's up to Ricardo to respond.
For sure. So the question is, why digital?
Right.
Right? And Stefan just showed us beautiful conventional work. So for me, the question of why has to be answered with, it's got to be predictable, and it's got to be efficient. If we don't have either one of these two, then it doesn't make any sense to go digital, because Stefan has proven that conventionally things work. Mm-hmm. So I want you to think about these type of patients that may walk into your office. The typical patient that has been restored with implants, and it's very upset with what she got. So she received this removable appliance when she was promised a fixed type of restoration. And as you can see, there are multiple locator type of attachments. Now she's miserable with this type of prosthesis. Now, according to what Stefan just showed, in order to sort of figure out what to do conventionally, that would mean making impressions, doing some wax rims, and assessing tooth position and whatnot. So again, this is day one. She comes to the office. So what if day one, and this is the information that she comes in with, this is not working, okay? You can see that she has a bunch of implants that are both shallow and facial, which is, for the most part, as we know, the kiss of death. It's very complex to treat this type of positioning of implants. So what if we go ahead and, instead of making conventional records, just go ahead and do an intraoral scan. And once we have that scan, we let her know that we're going to start figuring out if and when we're able to provide a fixed solution for her. Remember, that's exactly what she asked. I want to see if you can do something fixed for me. And we said, if we're going digital, it has to be efficient, has to be predictable. So we go ahead, we do the scanning, and not only do we scan via scan bodies the position of the implants, but we're also going to be scanning the pre-existing prostheses. And that gives us parameters that we can now work with to go back digitally and start figuring out if and when we're able to provide a fixed type of solution. As you can see, we discussed this before, those implants are too superficial, too facial. And so the screw access hole is coming out directly from the straight facial. And so what we do here is that we then go ahead and obtain what I call, quote unquote, a provisional Band-Aid, something to play around with, to show the patient if and when this can be fixed. We don't really know if it can be fixed because we haven't done anything for her as far as lip mobility assessment. We haven't done much as far as lip support assessment. But this provides us that opportunity, and it's relatively straightforward. And so bottom line, we try this intraorally. And again, this is appointment number 2. We realized that we could, right there clinically, do some subtractive reduction of the incisal edge and figure out a nice proportion of the teeth. And so basically modify clinically incisal edge position, and then from there, we can pretty much wax the gingival portion so that now the tooth has the right proportion. And from here, we're able to just convert the wax into acrylic once we see how much that lip travels with the wax. And so we're able to provide this solution day 2 and figure out if this is going to work for her or not. So we obliterate the screw access holes with some composite, and now we do the evaluation. We road test this type of provisional. And again, this is just done appointment number 2. And typically, for us to figure out if this is going to work for the patient or not, we're going to wait a good time of between 4 to 6 months. Now, with this lady, it took more than that. She actually came back a year afterwards. And she came back a year afterwards because she was very comfortable, and she was also saving the money to be able to pay for the final product. But what was very interesting, and again, this is something that we do every time we treat these type of patients, is we have to assess performance. And so with this, we have to see, first of all, the type of wear facets that we have in this provisional, if there's any fractured of the material. And this is resin. So we can see it's pretty intact. We also see that she's managed to have an impeccable hygiene. She's a very highly motivated patient. So this allows us now to very smoothly transition into a final result. So from here, we pretty much go and get our CAD/CAM generated prostheses. And as you see, the way that we're going to be dealing with that screw axis, as opposed to what Stefan showed in that first case in which he's modifying the angulation of the screw axis hole via a special screw. Here, because it's so facial, we figured out that perhaps the best way to go was just to cement a few crowns on top of the zirconium substructure. And so basically then deliver this type of prosthesis. Now, I'll be talking about that link between the provisional and the final as far as the impression goes momentarily. But the bottom line is as you can see, we're able to provide this type of solution in a fairly straightforward manner, in a way that we were able to jumpstart all the communication process by just digitally communicating with the patient and ultimately with the laboratory.
Okay, in the meantime, by the way, we got a lot of questions, online questions. I wanted to tell you, be a little bit patient because there are 5 questions regarding what is a take-home message. We will present at the end. Please be patient. But I have a question for Ricardo. Ricardo, I think it's interesting. How can you decide the occlusal plane when you do the digital planning? The occlusal plane. How can you do it? Decide it when you plan.
You mean the orientation?
Orientation, exactly. That's one of the questions. I think it's a very interesting one.
Yes, well, again, it depends what your reference is. In the case that I just showed, the occlusal plane orientation was pretty much where you want it to be, so it's just a matter of replicating it. And if you are modifying it, well, depending on what you see clinically, you basically go to the software and modify whatever you need.
Okay. Thank you very much.
You don't have the facial information to modify the occlusal plane virtually. So how do you do it?
So what you do have a picture of the facial, the dental facial integration, if you will. So you're guesstimating at this point. Remember, you're working on a provisional that can be modified. The fact that you're doing something digitally doesn't mean that the patient's going to take it home without you modifying it, as we'll discuss shortly.
I think what Irena was addressing is the topic, you don't use any face scans yet. You use pictures, slides.
For the time being?
And I'm just asking.
Yes.
That's correct, isn't it? Okay.
Stefan, how would you approach it? Because as I see
if I would do it digitally, maybe.
Exactly. Is it possible to register occlusion, the occlusal plane digitally today?
Yes, it is. You can make a face scan of the face. It's a three-dimensional impression, and you have something in the mouth like a face ball. And this face ball is you can use this face ball also on the STL data which you get from the intraoral scan, and then you can match both together, and then you have the face scan together with the STL data from the intraoral scan. And then you can construct your crowns digitally, and you have your occlusal plane because you can look at the face from all of the sides. That is something which you can already do, but you need a lot of knowledge to do it, and you can't do it from private practice. But we made experiments with that, especially Professor Reich, who is working with me in this field, and yes, it will be soon.
Okay, so if we look at the first parts of your lectures, Jörg, do you have any more questions to these first parts?
No, I don't think so, because many of them are addressing the take-home messages.
Okay, so we will come back to your questions, or at least maybe even answer them while presenting. If we summarize what you showed, and mostly also what Ricardo just said with his patient cases, efficiency seems to be a very important part of taking prosthetics to digital, from conventional to digital. You reduce the number of meetings with the patient. You may reduce maybe the need for a long collaboration with the dental technician. So is efficiency scientifically documented? Is it approved? Is it really, what can you say also from a university point of view on the point of efficiency in digital? Are we really more efficient digitally?
Okay, Irena, if we want to solve this problem, first, I think we have talked only about big cases in the moment, but your reality and also my daily practice is not all these big cases. We have also small cases, and therefore I want to give you a systematic overview how I manage my cases. So if we have a posterior implant case, then Yoda and co-workers, they presented a very good review about this topic, and they conclude that implant-supported single unit and short span reconstruction will benefit mostly from the digital trend. So not the big cases, the small cases will benefit. And they will benefit because we limit the production cost, we improve the time efficiency, as you already said, and fulfillment, the patient's perception of a modern treatment concept. That is the thing you told us, Ricardo. And therefore, in these small cases, I think Also, when you're working at university, you have to do it digital. Yeah. So we make a scan, we make a virtual design and production, we make monolithic restoration, and we connect it to prefabricated titanium abutments, and that's it. So in the end, if you see the workflow is completely digital. Only the staining of the monolithic restoration is conventional. However, if we go into the aesthetic zone, it's totally different for me, because monolithic restorations in high aesthetic cases is not sufficient in my eyes. So I need veneering, and if I need veneering, I need a model. And now the question is, is it the same when we use a conventional model, or is it better to use a digital printed model? And also, there's a nice study from Lee and co-workers, and they looked at 30 gypsum models, which were conventionally, which has a conventional impression, and 30 digital impression with a digital printed model. And the result was very clear. They showed that the accuracy of both models is fine. However, in the vertical dimension, there's an error around 0.1 millimeters in both models. So both models are not perfect, but they are so accurate that we can use both of them. So now I want to share with you, after this introduction, I want to share with you a case in the aesthetic zone, how I solve the cases normally. So here you see a situation which is really not simple. And first we extracted the teeth, we let it heal, then we made a bone augmentation procedure, in this case, let it heal, and then with a printed surgical template, which was digital, we start with the implant placement, and then that's important. Now we make a scan during the implant placement with an impression cap, and then we close the flap and let it heal. And during the healing period, we can construct now a provisional restoration. As you can see here, we have an abutment, we have a crown. We can produce a perfect emergence profile. And for second stage surgery, we will insert this crown. And in the end, we end up with a very nicely emergence profile here. So now I have to copy this emergence profile to the master cast, and this I'm doing with a custom impression coping. So I take the provisional, take a lab analog, put it in a container with silicone, and take away the crown, put on an impression coping, and realize this custom impression coping makes impression with that, and we came to a master model where we can have a Zirconia abutment which is perfectly fitted in this emergence profile, and we can start with the veneering process of the cemented crown. So here you see we cement this crown in the end and come to this final results. So yes, it took more than two sessions for me. However, with a patient with this problem, I think for him it's fine to come some more appointments into my office than only 2 times. So in this case, the checkpoints are, I make the surgical guide digital, the provisional digital, and the impression taking I try to make conventional again, because then I can make this transfer of the emergence profile on the master cast in a perfect way. And then the veneering process, again, conventional. So to round it up, scientific background on implant retained cover denture, there's no data about this. The only thing we are doing with removal partial dentures digital in implant dentistry is the CAD-CAM fabricated milled bar, because this is much more precise than the traditional casting methods. So to summarize this up, I have 2 things which are always digital. That is the surgical guide and the framework design. And I have the veneering, which is always conventional, And in complex full arch cases, as I showed, I'm working nearly only conventional. However, in the posterior area, we are only digital nearly. So that's my approach, how I will manage these cases.
So initially, it almost seemed like Stefan and I were talking about two different things. And in fairness, you will see that his thought processes and the way he treatment plans is fairly similar to what we do in our practice. So we were asked to address the question of when and how. And in order to do this, we would have to ask ourselves, in which world do we live? Considering that there are three different potential worlds. Which is your preferred workflow? Is it the analog workflow? Is it the analog digital workflow? Or is it the digital workflow? And my assumption is, hopefully, that most of us in this room live somewhere in the middle. Because there's no such a thing, I believe, as a fully digital. And I hope it doesn't come too soon, as we will momentarily see. So going back to this question of how do we decide and when? So I'll briefly give you this framework, which is part of our thought process in developing a treatment plan that allows us to, A, figure out what is the best solution for a patient, and B, which is going to be the approach to such solution. So we start with location, and by location we mean, are we working in the maxillary arch, are we working in the mandible, or both? The next thing we think about is the etiology of the problem. So sometimes we deal with patients that have terminal dentition, sometimes we're dealing with patients that are already edentulous, but we have to know what happened there, why the patient lost their teeth, why is the patient losing his or her teeth? And last but not least, we look at the condition, as I'll momentarily go into. And so again, location-wise, I believe it's very important for us to assess the nature of the patient's situation. And so these are three different scenarios that we may treat differently. We have a patient that has a terminal dentition. We have a patient that's already experiencing a healed edentulous ridge. Or we have a patient that has ill-conceived implants restorations that now we have to figure out if we're going to be keeping or if we're going to be explanting and redoing surgery and placing new implants. So the next part is etiology. Why is the patient losing their teeth? Is it a structural issue? Is it a patient that has advanced decay? Is it a functional issue? Is this a patient that has severe parafunction that's breaking everything? Because this right there will also impact not only our design, but it will also impact what the patient will do with whatever we provide them with. And last but not least, if and when there is a biologic susceptibility, advanced periodontal disease that's causing such tooth loss. And so the next thing we do is we look at the actual condition. And for the condition, we utilize a very simple classification that we are very close to publishing in the IJPRD, what we call the LTR classification. I was very fortunate to work with Dr. Adrian Polini. He's a periodontist, prosthodontist, who just finished his dual degree. And Jack Goldberg, who is my partner in practice in Mexico City. So we were talking about how can we relate these three fundamental components in the thought process: the tooth position, the lip, and the ridge. And I see a lot of scientific people in the audience. And you can look at Siebert's classification. You can look at a whole host of different authors that have looked at ridge defects, relative to tooth position. What we thought was important here is to figure out and to factor lip mobility with tooth position with ridge configuration. And that right there allows us to see which potentially is the best solution for a patient. Is it a removable solution because there's lack of lip support? Is it a hybrid solution, or is it a more sophisticated implant-supported dental prosthesis? Again, generically, these are the three options that we will typically offer to patients. And so once we figure out where we're going with these patients, then we map out where will the digital portion of therapy play a role. Okay? So the other thing, of course, all this is clinical. The other thing has to be personal information. What's the patient's compliance? What do they want? And also, more importantly, what can they afford? Because these type of restorations, of course, have a different price tag. And so all these need to be fully accounted into the equation for us to make our decision process. All right? So let's look at this patient. Patient comes in fully restored and has a lot of disease. As you can see clinically and radiographically, there's a bunch of restorations, but a lot of disease. And as we're figuring out if we're going to be keeping some teeth or removing some teeth, we figure out that pretty much everything is gone here. And so, can we go ahead, scan him digitally, and map out a way of placing the implants and jump-starting things in the name of, I did it really fast, as I showed you that first case? In a patient specifically that has already gone through implant therapy, a patient that is pretty upset, if you will, with dentistry. So, for these type of patients, we decide to go with no shortcuts. And no shortcuts means, again, we go through a classification. It's mandible and maxilla. The etiology is both structural, but mostly biological. He's going to be a class 2. He's pretty compliant, and he's got a lot of money, which means we're going for an implant-supported fixed dental prosthesis. So utilizing what we call the phagally generated treatment planning protocol, and this is basically from Spear Education, we figure out what is the tooth position relative to the phase that we're going to be utilizing as a reference. And guess what, Stefan, Irena, and Jörg? We're going conventional. We're making impressions, we're removing all the hardware, and we're placing immediate dentures. The good, solid, conventional approach. Once those ridges have nicely healed, then, just like Stefan said, we can plan the next stage to digital and do CBCT imaging and figure out where we want those implants to be. Before the implants go in, though, we do a duplicate of that immediate denture. We remove the flange, so we ensure that we're able to do a flangeless try-in to see if we can, in fact, provide a fixed type of restoration, if the patient will be able to utilize it, and from a cleansability standpoint, be able to work smoothly with it. So we do our lip support try-in. And then, of course, the implants go in both arches. We decided to place 6 implants in both arches. And as far as the loading protocol, we do a conventional protocol, as opposed to what I'll be showing you momentarily in other cases in which we're doing this in a more digital approach. But here it's pretty much conventional. We're converting the patient's own immediate dentures now into fixed type of restorations, both in the in the mandible first, and then in the maxilla. Right? And so you can see here, same very straightforward analogic conversion protocol. And now the patient has a fixed restoration in the upper and the lower. Okay? Now, what happens as we're done converting these? Or potentially, what can happen? What happened to the patient's incisal edge position on those maxillary teeth? They were basically intruded. And why is this? Because of that conversion error. As we were converting it, we basically put too much pressure on that immediate prosthesis. So once we do the pickup, we realize that now we don't have a right tooth position. So now we have to go back and perhaps digitally enhance the tooth position and provide this patient with what we call CAD/CAM generated now protocol provisionals, which can now serve in the patient's mouth pretty much long term if we decide that. Now we're going to be road testing this patient again to see how he behaves, because at this point, we want to make sure, based on his performance, what are going to be the materials of choice that we're going to be utilizing, again, to provide, as much as possible, a long-term solution. So now the patient can navigate with these type of provisionals 6 months, 8 months, maybe a year. And so once we ensure that we're having a smooth ride, is that we are now moving on to the definitive solutions. But again, it has to be based on a prototype in which both clinician, patient, and technician is fully aware of where that tooth position is, and we're all comfortable with what we're delivering to the patient. Just to give you an idea again of where we were coming from and how we've stabilized the patient at this point. And now we're basically ready to move to the final. And again, here you can see that we're, for the most part, utilizing we shouldn't say for the most part monolithic, right? You either are pregnant or you're not pregnant, right? So we are doing minimal layering in some cases, okay? But all the occlusals are pretty much in zirconia with a patient that has shown over the period of time here that's pretty low function. So now we're comfortable doing this. This is not the type of solution that I would do for all my patients. Many patients, as I'll show you, we end up utilizing dissimilar materials. We may go for all zirconia in the maxilla. We may choose to go with a titanium and denture teeth in the lower as well. So all these combinations are based on performance and finances, as I said. So this is the work of Domenico Cascioni, a phenomenal technician. He's based in LA now. And this is here the final result with a patient that's performing very well with this type of prosthesis.
Well, we have to say it's really beautiful, and thank you very much, Ricardo, for sharing your cases with us. We come back to this question of efficiency. Until now, we've really discussed these full arch, complex cases, but that's not our daily clinical life. And we have to say, not all of us here in this room are experts like the two of you are. You can deal with digital technology. Whatever technology comes along, you know how to use it. But what if somebody just starts using it? And what if the practice is oriented differently than your practices are? Stefan, is there any research that shows us?
Irena, I think it's very important that we are not talking always about the patient, but also how we ourselves are dealing with these methods. And Yoda performed a very nice study about efficiency, and they compared digital and conventional impression. It was a little bit unfair in my eyes because the impression was with the intraoral scanning only one quadrant, and the conventional was a full arch impression. It was made on a phantom training Einheit unit, and I'll show you the results. The work time for the intraoral scanning was shorter. For students and for dentists, it was only 4 to 5 minutes, and for the conventional, it was between 10 and 12 minutes. So that's not something which is really challenging for me, and because we scan only one quadrant and we make the whole arch impression. So that's a little bit unfair. But it's clear that the efficiency of these methods, the students voted in 88% and the dentists in 64% that the efficiency is better with the intraoral scanning system. That's clear. However, and that's now very interesting, the preference was for the students, it was 76% for the intraoral scanning unit and only 26% for the dentist. That means the students who has to learn both, they don't know both of the systems very well. They decide to go for the digital way because they come out of a digital world. The dentists who are very good in conventional impression, they have it much harder to say, okay, now is the right time to change my way of making the impressions. And I think that's the reason why the preference is so different between students and dentists. If we go to the efficiency of monolithic implant crowns in a digital workflow, also there's a very nice study by Yoda and co-workers, and they have had two ways to produce crowns: a monolithic lithium disilicate crown without a physical model, and on the other hand, a Zirconia crown, which is veneered on a milled model. So, and now if we go to the total work time in the clinic, then the difference is not so high. It's 20 minutes for the monolithic crown, 24 minutes for the veneered crown. Ricardo, in my office, that is not a very important time, 4 minutes, but perhaps in your private practice, yes. On the other hand, you can comment on this later. In the total work time in the lab, I think that's also at a university setting a big problem. If you have the difference between 45 minutes and 132 minutes for a veneered crown. So that's something which change also the costs. And so it's very clear that we have a 30% reduction of costs when we go for the monolithic restoration. So this is much more effective, I have to say.
Stefan, I have just one more question.
Yeah.
What you were presenting is, it looks like for the young generation, they love to go over a digital workflow. Is this what you're teaching your students in your university, or are you still at the beginning? I think that's an important question for everybody.
That's very important.
Here.
I'm 49 now, and so I thought it's good to have a professorship for digital workflows in my department, because I could not handle all of this. I'm very happy to have someone who is working always on the edge of the things which is possible today, and I am catching for myself only the things which are already in a normal workflow. So that's really what I'm talking about today with conventional digital. That's really my life. And so I'm telling it to my students. But I understand completely that the students will have a totally other view of the world, because they will never work with a wax up or something, because they can do it from the first beginning digital. So they will have something else in the mind, and so I think they will do it really different.
How is it in Geneva, Irena?
Well, it's exactly the same way. You see, it's definitely a generational matter. I think our generation has a little bit more resistance to adapt to technology and to change the workflows that we are used to do. I think for the students, you don't even need to explain them how to use the machines. They already do before you just start explaining. So it's sort of also frustrating for us a little bit, we have to say. But we have to cope with this, and I think it's a very good approach to have specialized partners in specialized units which deal with this. How did you learn all of this, Ricardo? When you're in a private practice, you're treating patients all day, then you're lecturing when you're not treating. When did you learn, and how did you decide how to invest in all this technology?
I didn't learn yet. I'm learning it.
You're still learning it.
But you're pretty advanced. From a point of view, they're still learning.
For sure.
Anyway.
For sure.
Okay.
Well, in the end, let's see, Stefan and Ricardo, how you integrate these new workflows in your daily lives.
Irena, for me, selection of material is a very, very important thing if we talk about digital workflow. So when we have restoration on implants, then the gold standard is metal ceramic. And we have very good survival rates over 10 years. So it's between 95 to 93% a survival rate for crowns and bridges. And we have chipping, which is not so high. It's between 4 and 14%. If we go to all ceramic restoration, zircon oxide with veneering, then we have chippings between 10 and 50% after 2 to 4 years. So that's something which is really difficult, I think, especially in the area of the where you have a lot of chewing
forces.
Yeah. And therefore, I think it's clear when we think about all ceramic restoration, we have to think about monolithic restorations. The advantage of this is that we reduce the chipping, that's clear, and we can perfectly integrate it into a CAD/CAM workflow. The only question is, which material should I choose, lithium disilicate or zircon oxide, and how is it with aesthetic and longevity? And I want to go a little bit into this detail. Again, Yoda it's the most famous name in this area in the moment scientifically. He has a study with 15 screw-retained monolithic lithium disilicate crowns, And the survival rate after 2 years was 100%, and they have had no problems with technical or biological complication. But 2 years is nothing. So it's a nice study, but we need longer results. And I'm proud to can present you today this study from the working group of Kohal from 2017, and it shows the 5-year results of lithium disilicate monolithic crowns, and it's 100% survival and 91% success rate, also very good data. So it's the first time, for the first time this year, we can say, okay, we can use that also from a scientific point of view. If we go to monolithic silicon oxide, and that's something which will be interesting also for you, it's much more difficult because we have different generation of this material. So interesting is the second, altogether we have 4 generations now. The second generation is very interesting because they changed the grain size and the number of the aluminum oxide materials, and therefore we get a higher transmission of light and with a good long-term stability. About the 3rd and 4th generation, we have no data at all, so they are not older than 2 years in the moment. So if we go back to the 2nd generation, then you see here the flexural strength, which goes from the 1st generation, 1,200 to about 900 with the 2nd generation, and to about 600 to the 3rd generation. And lithium disilicate, as you see, it's lower, so it's high enough, I think. And the good thing what you get when you're going down with your flexural strength, then you get a better translucency. The translucency is getting better from the 1st to the 2nd to the 3rd generation. However, it's not as good as with the lithium disilicate, as you see here. So if we summarize this, then with monolithic zirconia, we will have no problems with cracking, I think. However, perhaps we have problems with the antagonists, which get wear of the zirconia restoration. And there, I can also show you a study from 2017 from Lobauer and Reich, and they showed for the first time that the antagonisten wear after 2 years was acceptable. It was only 0.1 to 0.2 millimeters after 2 years. And this is in line with other studies, but they looked for this fact only for half a year or 1 year. But I think we could be a little bit more safe in the moment with this restoration when we made a very, very good polishing of this restoration. So let's come to the aesthetic. Left hand, you see a veneered bridge. It looks nicely. And on the other side, you see a monolithic restoration with a multi-layer block. I think it's also nice. And both restorations has a very good aesthetics, and we can use it in nearly every case. When we talk about the aesthetics of the stained monolithic lithium disilicate crowns, you see here an example. It's also something which is very nice, especially if you have not a single crown, if you have to crown all the teeth in the aesthetic area or some of them, then you really get very nice results, as you can see here. So when we put this together, and I always try to give you a concept of my work, then we have to see it in on different pages. So we have long-term survival, we have chipping, we have antagonist wear, we have aesthetic, and we have the strengths. And you see it here categorized in only 3 categories, red, yellow, and green. That's international. So let's come to the first situation. We have one implant in the aesthetic zone. There, I need the best aesthetic results. And therefore, in these cases, I still work with lithium disilicate or zircon oxide veneered, even if I'm not really sure how good the long-term survival rate of this restoration is. If I go to multiple restoration in the aesthetic zone, then I go to lithium disilicate monolithic, because I get very nice result, not as good as with veneered, but good results. And on the other hand, I have 2 studies now which show that the middle term survival is fine. and we can postulate that we have no chipping with that. If we go to the posterior side with single crowns, I stay also with lithium disilicate monolithic. If we go for small bridges, I stay with, you can use zircon oxide monolithic because we have good aesthetic, as I showed you. We have no chipping, that's postulated, and we have no antagonistic wear, not too big antagonistic wear, I have to say, that is shown in studies. On the other hand, we can use, to be on the safe side, metal ceramic also in these cases. If I go for full arch cases, I always use metal ceramic because we have absolutely no data on this monolithic, very nice bridges which you have shown us, Ricardo. And with that, I want to hand it over.
Let me go back to Ricardo.
So going back to this efficiency concept. And again, as you'll see, conceptually, both Stefan and I are pretty compatible with our thought processes.
What's the timing?
But let's go back and think about this patient visiting your office tomorrow morning. Okay? Again, patient that has been previously restored and that has a lot of mobility in this upper bridge. Most likely, you'd be removing those teeth if you were to do implant alternate impressions to figure out the next components of therapy. So we could build an argument of being very careful and keeping those teeth, even though they're incredibly mobile. But let's assume for the sake of discussion, you could make an alternate and then treatment plan for the rest in a conventional manner.
That's a silly question.
Or let's, for the sake of discussion, say you're going to go ahead and treat them digitally. And at this point, be able to do the dual technique. So we're doing intraoral scanning, CBCT imaging, and merging both data. Now, for the sake of treatment planning, we all may have different concepts as to number of implants, whether to keep some teeth or not. So this is a part of a broader discussion, but ultimately we decide with this patient that we're going to go for a full arch reconstruction. Now, many of these types of protocols and these types of systems basically call for having a third party doing the milling and a technician that works the software. This happens to be a system called N-Sequence in the US. My assumption is that in Europe you have all sorts of different systems. And my assumption is that very soon we're going to be able to mill in office most of these type of prostheses if we wait long enough. So basically here we are discussing with our technician who's in the US and trying to figure out what's the exact position that we want for each implant. Now you will notice that the patient had a previous existing implant. And because of the nature of the design that we want, that implant is in our way. And so we ultimately need to now remove that implant and place a new implant in that position. You know, back in our program, Dr. Ralph Udelis, years and years ago in Washington, says, never leave the pulp of a tooth interfere with a full mouth reconstruction. Mm-hmm. And he moved on to say, never leave one tooth interfere in the reconstruction of a full arch. Well, now, never leave an integrated implant be in the way of a full arch concept. And so again, I mean, we are torn in this idea of to extract or to keep. And I see incredibly famous periodontists in this audience that would shoot for keeping some teeth. We have right here Dr. Ricci sitting front row. If you see his work, you see he's able to keep many teeth that probably 90% of the population wouldn't. So that's a different discussion. The concept is, if and when you believe in doing something because you had all the parameters that you measure to take that decision, then what do you need to do it and to do it right? So you don't experience chipping, so you don't experience failures, because at the end of the day, we don't want our dentistry to fail, right? And so basically from this now, having all this planning, oops, this is digital and it's not working. So now the system will throw all these quote unquote stackable elements. So we have a stereolithographic model. And then, as opposed to the first case that I showed you, now we're going to have a foundation guide that we're able to place. And from there on, we're going to be stacking the different components, just like if they were sort of like Lego pieces, right? And so we're going to start, of course, and we also have a provisional that's milled. And so, again, that will provide a stable means for provisional pickup. And hopefully, if all thought right and done right, you're pretty much getting from point A to point B with the smoothest ride and with the least amount of steps. And this is not a competition if I'm done in 4 appointments or 5 appointments. It really isn't. But it's about stretching the envelope and trying to see where we can cut corners and where our work is going to get us from point A to point B in a more smooth fashion. So we start, of course, with the extractions and trying the first of all these guides. And we assess again that we're nice and stable. Now, for these type of systems, the flap design is such that you have to open and raise very, very big flaps to ensure that the bone foundation guide is seated all the way. So, you know, for very conservative surgeons, they have to really raise a very, very big flap in order to get this on its way. Then you're going to place the bone reduction guide so that you know exactly how you want that bone to be basically modified to allow for the implant, to allow also for the intaglio surface to be nice and convex, and it's cleansable as well. Now, in a case like this, because next stage is going to be implant placement, we have to remember that whenever we're placing implants in the sites where we had teeth, sometimes the planning can be a little bit misleading. So everything that we're planning at the end of the day, when the surgery comes, we may need to move that implant position bodily a bit to engage solid bone and to have nice primary stability. And so there may be this leeway factor. We're not robots yet that we place the implant just as we planned. We have to realize that this type of guided surgery and digitally enhanced surgery also calls for clinical expertise and a lot of thought process and decisions during the procedure as well. So anyhow, then the implants go in. And as I said, if we need to modify the position here and there of one of the implants, so be it. I mean, but we do it in a contained fashion. So we have to do it like in a multi-step approach in which we're containing and we're controlling the step-by-step. The drilling sequence is done smoothly, and then, of course, go ahead, we place our implants, we place our SRA abutments, we have sandblasted our components previously, and so now, as opposed to that previous case that I showed you, we're going to be utilizing what we call a gasket that insulates the area. And so the system allows now for us to seat that provisional. And if you did the homework right and the flap was open right, then you're truly capturing that position exactly where you need it. So I'm seeing here in front row seated my very good friend, Pepe Suarez Feito. He's done hundreds and hundreds of arches along with Alberto Sicilia. They have a technique that it's bulletproof. For many of you that are struggling with which is the right technique, this right here offers you a good solution. It offers you a good solution because it really relieves you or takes away the fudge factor of mispositioning the guide, if you will. So next thing you got to do is the pickup of the provisional. We have this record that stabilizes the teeth where they need to be, and as you can see, we have these perforations through which now we're going to be injecting our light curing material to make sure that we now capture the cylinders. And so once we have them captured, it's very simple to just go ahead and remove them while the patient is, or while the surgeon is suturing. We go back to the lab and we now modify this provisional. We close those screw access holes, and you can see how pretty much thoroughly those perforations were where we did the pickup. We didn't open them too wide. Now we close them up with composite, and more importantly, we're now going to be working with the intaglio surface. We're going to work on the emergence profiles so that we're creating a nice healed ridge that will allow for nice cleansability and for the patient to be able to maintain it long term. So if you did your homework right, this is the second day you see the patient. And again, I'm not claiming that these are races, and I'm not claiming that we should do this in less and less appointments. I'm just saying it's feasible if and when the stars are aligned. And there's nothing wrong with expediting processes. At the end of the day, we said digital should be more efficient, right? Now, once we're able to provide the solution to the patient, and again, we ensure that all these contours are nice and cleansable, take a look at the tooth position relative to the patient's face. It's pretty much there. Now all we need to do is minimal modifications to go to the final. Now, just like Stefan very elegantly depicted all the steps of what he does digital and what he does analog, well, here you can see like a representation of everything that was done surgically for this patient. But now that those implants are integrated, the question is, should we trust digital impression for full arches? And you showed some data, and I saw Wael at somewhere in the audience. His group has done very nice research. We still stick to conventional impressions. And we still stick to my good old virtual material that I've been using for years and years. Nothing wrong just to say, in the name of I'm doing digital dentistry, do procedures that do not provide yet, I'm not saying that they won't, do not provide yet the ultimate passively fitting restoration. So now, if you see, we're just doing minimal modifications, and we wanted to plump out one tooth a little bit. So now we're trying this. And Stefan also talked about occlusion and how occlusal records digitally he's not too comfortable with. So what basically we're doing is, from those modifications, we're going to do a try-in only utilizing 3 cylinders. Yeah. We take it to the patient's mouth, we we'll go for occlusion, and now once we have the occlusal exactly where we want it, when we go back and we ask that technician to copy mill something that occlusally has been proven clinically. And so you see, the discourse is not that far off. We disagreed initially, but ultimately we're pretty much on the same boat, right? And so this here is a monolithic restoration. Monolithic, no layering. No layering. Okay? And again, a patient that has proven to be pretty low function as well. And so we're able to provide this solution. Now, many people always ask about bone reduction guide, and people stress about removing bone. And so I'll tell you this much, which is, I think, very, very important when we look at this patient. If you take a look at lip mobility, even in an elder patient, and he's in his 80s, had we not done the right amount of bone reduction, you could see the interface of that prosthesis showing as you look at those buccal corridors and you see that gingival area there. So that has to be tied back to what I told you of the LTR of lip, tooth, ridge classification. We need to assess lip mobility in order to make our assessment and make our guided surgery where we want it to be. So now very quickly, remember I showed you this patient a while ago. From a positioning standpoint, you may have some errors in position of the provisional, and that may set you back. When we talk about position, we're fundamentally looking at 4 different aspects. We look at the incisal occlusal plane orientation, because there may be a bit of a cant. We may also experience some discrepancies if you look at the intercuspal relationship. We may also end up sagittally also modifying the tooth position, and ultimately the vertical dimension. If the patient closes too much, we may collapse the patient, as opposed to having a fixed device during the pickup that then allows us to go much smoother into the final. All right? So I'm going to give it back to you.
Maybe raise a question from the audience about
exactly.
the emergence profile.
Well, there's 2 questions that are coming in numerous times.
Mm-hmm.
One thing is first to you, Ricardo. The audience would like to know, do you design and do you choose the type of restoration, which you do in the full arch cases, differently if it's done in the maxilla as if it's done in the mandible? Or is it the same concept in both jaws?
And the answer would be, it depends. It depends, and depends on what do we have in the opposing arch. If it's going to be a double case, double maxillary case. It depends on finances. It depends on number of implants. So it's a multifactorial issue. I mean, I would be okay using any type of design in either one of the arches. Typically, if you're able to do, a ceramic reconstruction in the maxilla, you could probably move to a hybrid in the lower. But again, it depends on many factors.
Okay, so maybe this may be also a topic that might be discussed in the studio discussion later on with the two experts, because I think it's really a relevant question. Another question that came in several times that we thought is really important is, how do you transfer emergence profile that you created with your provisional now digitally into the digital world, into the final reconstruction?
I think, Stefan, you showed us how you did it when you're going the conventional way. Yeah. But maybe Ricardo should give us some information about the question that was even more precise. Just copy the temporary or you design it on the screen, on a computer screen, or maybe you can say something about it.
Yeah. For me, and again, there shouldn't be a why not being able to convey the emergence profiles that you get digitally, but copying it or being able to transfer it analogically, it's a very, very smooth ride. So for now, today, we're still doing it analogically.
Okay.
Yeah.
Stefan, are you doing it analogically or digitally?
I do it myself, like I showed you.
You showed us.
However, I'm talking a lot about this with Professor Reich, and he said, I can do it if I'm very quickly, taking out the provisionally and scan the gingiva very quickly. I think that's possible. Mm-hmm. It's because you can scan it faster than you can make an impression conventionally. That's the reason why it's not possible conventionally, but digitally, I think, when you only have to, when you go with the CEREC system and you make the gingiva mask, you can take out the provisional, make the scan, and then you have it.
But it only works if you have maybe 1 or 2 implants. If you have more implants, you are too late. You're going to have a relapse of soft tissue.
I'm too late for sure, but I'm not sure if he has. No, you can do it. That's something I think which is interesting, especially with the CEREC system, because here you really can cut off areas,
right?
And then you can make scan after scan. I'm not really sure if this is possible if you have only gingiva. There I'm not the expert, but I think that will be possible in near future.
Okay.
Okay, so let's see now in the last final part of this lecture, what are the consequences for daily practice from your university point of view and then also from the practice point of view? So, Stefan.
Ricardo, our talk has showed me that I really have to change my concept and go also for a little bit digital. And there I really look to the literature, what is published about the learning curve which is before me. And I think that's also something which is before you. And there's something which is not very positive, but it's positive in that way that you know that your learning curve will be flat. That means it takes a long time so that you have learned everything. I think reality is very much different to the things which the companies tells us in this way. For me, but perhaps I'm the only one who has, for whom it's sometimes difficult. Why is the learning curve initially flat? Because you have to learn these complex scan passes. And these scan passes are different for every system. And you need these scan passes to have correct measurement at the end. Then preparation margins. To get a picture like this, you really have to have the right curves which you are put into the cycle so that the cycle is open during scanning. You need a very, very good periodontal pre-treatment so that you have no bleeding at all if you're using powder. And there are good systems which are using powder. And so this is really not easy, I think, but you can learn it. And in the end, when you have made it, it can be really beautiful. It's much more easy in this context with implants because the scan body to scan is really easy. I think that's something you should begin with because you can't do anything wrong with that. So the only thing you can do wrong with scan bodies, and I talk now about my own experience, is that Normally, for implants, you have a specific impression coping. For now, you have for implants specific different scan bodies, and they must be compatible with the CAD software your technician is using. So you have to talk very much with your dental technician to get the right workflow for all these steps. That's it.
Well, Ricardo?
Well, I'm going to try to be a little bit thought-provoking with this closing remarks. If I may have the slide in the back. Okay. So let me ask the audience, what do you think is the biggest dental lie? And perhaps you can think of many. But over the course of the last 20 years, a dental lie that I listen to every day is patients coming in and saying, implants are forever, right? And I don't know where this concept creeped in, but everybody seems to say implants are forever. And we know for sure this is not true. Implants are not forever, and implant support restorations are not forever. We have problems, and this is the reality. And we have problems because the intraoral environment is very hostile. So for me, the concept is not to treat these patients, but to manage them. You know, I was sitting through the last portion of the lecture with Joseph Kahn and Marcus, and, you know, we're struggling to do our best to help teeth that are, you know, so destroyed and get the tissue where we want to. I mean, I think we're doing a fairly good job. Sometimes we just hit ourselves too hard, you know? We manage situations that are complex to manage. If we look at other sides of the body, you will see that the time frame it takes for these types of replacements to need to be replaced over and over. You look at limbs, and this is a website called amputeecollision.org. I mean, these things are guaranteed for 3 years. Hips, eyes, I mean, and so forth and so on. You look at the most sophisticated technological, devices out there. Will they last forever? Well, same deal with what we do. Is this going to last forever? And so, tough question to answer, but the reality is we have to come to terms with the fact and let patients know that things will work in a patient's mouth based on their use or their abuse. And just as patients sometimes abuse their own natural dentition, they end up abusing whatever we do for them. And so it's all based on a discussion that we need to have with patients. We do our best, but we work in a hostile environment. And I cannot say this more emphatically. We do have reconstructions that look very nicely 1 year, 5 years down the road, 6 years down the road. And sure enough, we do get patients that come back like this. For sure we have. And we experience these type of troubles. And now we have to rethink our designs. Should we now beef up our connector sizes and whatnot? The key, though, is how you communicate with patients. You see, this patient had provisionals. I told him, I'm going to have a very sophisticated scanner and see what's going on with you because you are in the verge of creating trouble. My friend, you are the ultimate terminator. No matter what I put in your mouth, you're going to end up breaking and breaking. So this is a conversation that we need to have proactively with patients. And so what are the weakest links in these type of prostheses? Well, we got to think of either the framework, the abutment interface, the abutment screw, the actual osseointegration of the opposing dentition. So we have these discussions with patients, and at least, it just becomes a totally different discussion. So the difference between failure and complication is, I told you this was going to happen. So if we want to play God and say, I'm going to give you this is going to be great for the rest of your life, then we are shooting ourselves on the foot. So just wrapping it up, from which world do you live in? The analog, digital, or digital? Because the take-home message for me is to understand that the most important workflow is the neurological workflow, the thought process. I mean, you can walk through any type of workflow, but we got to think. What digital means is that technology increases and knowledge turnover just goes on and on with the economy and society. That's granted. If you look at Aldous Huxley's work back at last century's work, he says that 3 pillars of Western prosperity were armament, universal debt, and something called planned obsolescence. So think about this. Our devices, our scanners, our phones has a planned shelf life. So the key with digital is to understand that whatever we're utilizing today, there's a very big implication as far as how much we are investing in private practice for these type of things. Well, we got to make them work. You know, as I see the audience, I see a mixed match of older generations and younger generations. There's a great book called the App Generation. And it talks about basically two types of groups, the immigrants and the natives. For us immigrants, when we did presentations, this is what a full day of lecture looked like. 36 carousels. Today you can have a full year of lectures in one thumb drive, which is great. Absolutely. So what do you do with 40,000 slides that you can no longer use anymore? Well, you figure out how to use them. So we did a little slide panel in our office that at least it becomes like a piece of a museum. So to wrap it up, I would submit that the more we think about digital, the more we have to think of a digital tool, because it is a tool that allows us to make our lives easier. And I guess I'll wrap it up saying that in the era of the scanners, the toughest scanner to calibrate is the one that is sitting on top of our shoulders. So,
well, I guess said so. I think we agree. So to wrap up the entire session and all the messages that you've heard now, I think there's a lot of positive thing about digital technology as compared to conventional. But the purely digital workflow, everything done digitally, communication included with your patients, is not there yet. So there is some things still to be developed and evaluated. The efficiency of the treatment is definitely improved, and I guess both of you have really shown nicely how we can reduce the number of meetings with our patients, reduce the treatment costs also, and really increase the efficiency of everything. Patient documentation, diagnostics, communication, and most importantly also the storage of data is definitely a big advantage of digital technology. It helps us also reducing space needed for storing costs. Well,
Irena was presenting you now the pros. I'm presenting you a little bit the cons. And you see, not all dental materials can be processed using conventional technology. That speaks for digital. Digital technology implies a learning curve. We heard from both speakers, it takes time until you are at a certain level. It's not only you. You have to integrate the whole dental team, including the dental technician or master dental technician. And last but not least, I think a borderline is still today the high costs for the acquisition of buying the hard and soft software to be considered. Lastly, we couldn't address all the questions that were sent to us during the 90 minutes, but you heard that you can go online and the two speakers will be around anyway. You can approach them. You're very welcome. Last but not least, I would like to thank you. I would like to thank the two outstanding speakers and my co-host, Irena. Thank you so much.
Thank you very much all together and have a great rest of the meeting.
Okay.
Speakers will join us in a moment. They'll be walking out of. So welcome to all our online viewers. Welcome to all our people here around the studio here at the Digital Village. Stay tuned because the speakers are being demiked and de-rigged, and we're gonna ask more questions about them. And when I say we, my name is Gerrit Heijkoop. I'm your online host, and I'm joined by Ali Tamasep from Amsterdam in the Netherlands, by Vincent Famer from Geneva, Switzerland. You guys have been standing here with me following the session. For our online viewers who tuned in later, how would you summarize the key message of what we've just heard?
I think it were both very interesting lectures. Looking at the stuff from different perspectives. We had the clinician guy who tried to do as much as possible, implement the digital workflow. And we had like a more holding kind of academic guy who really respectfully tried to really thinks about the things over before implementing anything. So two different lectures. I think it's all about what we call the reverse dentistry. It means that we first think about the planning and going to the patients. We saw really some nice cases where the implant were already placed, by other colleagues and other treatments where the position were not really right, and we saw the difficulty to get those things right. And I think what we can summarize that at least we have the digital workflow. The one thing we are really can be sure about that is can be implemented today is a planning part to avoid those kind of complications, to avoid those kind of not necessary treatments that can follow. We can use that technology already. Exactly. So for me, what's the most important thing that is really we see that these people are really implementing that, and they are bringing the message that can be really done already.
Yeah. So yeah, and that is what you should understand about this section. We're gonna try to bring these rock stars on stage almost, and with their magnificent cases that they presented, which might not be representative for every day-to-day clinical practice. So what we're going to do here with them and with you is actually bring down the takeaways to a much more practical level. And we're going to address some of the questions that you're typing in. And if you're still with us, this is the moment to type in your questions in the comments and let us know. I already saw some nice questions from Sarah Renfield. We'll definitely take yours. Eric Suter, thanks for your shout out. Naomi Lau, we saw your comment about your audio problems, but we think you were able to fix it. We've checked all our systems, and from here everything is going smooth. So I hope you can hear and follow us properly. Vincent, from your perspective, what do you take away from this session?
I mean, first of all, we have to congratulate the two speakers for two terrific lectures. And what is clearly shown that none of them works complete 100% digital, and all of them use digital technology. So conventional, I would say, on a 100% conventional A to Z treatment is out.
That is not there anymore.
I think the biggest goals is the communication tools that you have today, the interaction between surgeons, general practitioner, dental technician, industry that really helps you to make sure that we have this reverse dentistry, the backward planning, that we know and define the aim beforehand, and we have the tools to bring it down to the final treatment. The next critical aspect is the materials that we are accessing today, the new materials, they have to be manufactured based on CAD/CAM technology. So in order to use those new technologies and new materials, you have to have a digital tool in your, in your lab, in your office. Without this, you are not able to offer these stronger, longer lasting, more aesthetic materials to your patients. So there, for sure, we are today.
And in our little pre-show, we already talked a little bit about like digital is so broad, like our moderator just summarized at the end. We're also looking at investments, both as a person mentally adapting to change, as financially. And you're basically saying this is a step that you cannot overtake. That is where we start.
Mm-hmm. Yes. Mm-hmm. If you want to go into this direction, especially on producing the reconstruction, the final reconstruction that the patient will receive, you have to invest.
Yeah.
You have to invest into any kind of CAD/CAM devices that can either be in a dental office, they can be in a dental laboratory, they can be supported and given to you by an industry partner, so you don't have to buy it for yourself, but you can interact with them and have them produce it for you. So, but you have to have the access to it.
It's true. I think, as you mentioned, is a very important point. Some steps you have no choice. Yeah. Some steps is digital, whether you like it or not. You cannot change that. So, and I think it's going to be towards this direction. So we're going to see more and more these kind of steps. I think the first thing I'm thinking about would be the impression taking. I don't think that we're standing here, let's say in 5 years, talking about analog impression taking.
Probably not.
So it's going to be out.
Yeah. So we have imaging first.
Exactly. That's already happened.
Impression taking is the third step.
Yeah. And with we saw some cases when they showed monolithic crowns and monolithic restoration. I think that also goes toward that direction. But a most important point that Ricardo also pointed out at the end of his lecture is that you still need your brain.
Exactly. You cannot digitize your
brain.
Yes,
you need the brain still. So that's an important part.
Yeah. And I see in the questions online also that our viewers would like to start to explore with the speakers the edges of this, right? Because somewhere in the beginning of Stefan Wolfart's talk, we saw this very clear you refer to German matrix of steps of the workflow that can be digital, and it was clear that especially when we talk to a full restoration, we cannot go digital yet, and obviously our viewers want to know when might we go there or what does that look like. So we have that for you ready. In the meantime, while our speakers are making their way from stage to our studio, let me give you a quick show around. As I mentioned, we're in the middle, we're right outside the Madrid room. We're in the middle of the digital village. And if you've ever been to an EAO Congress before and you wonder, digital village, what is that? It is part of the innovations here at Congress. This online Congress is part of it. The second part is the digital village with e-posters, with the online library there. Yesterday, we asked Isabella Rucheta, the EAO board member, EAO board member, to take us around and show us more about this digital village.
This year, the EAO is making it easier than ever to access the scientific and your research content. And as part of this, let me introduce you to the digital village, which you will find in the middle of the exhibition hall. The digital village will show 500 posters every day, all day long. And we have these special digital panels, which will show you the posters instead of the traditional paper ones. The posters will be divided into 6 distinct categories. This will allow you to choose, according to your level of expertise or the topic of your interest, which one you want to see. Make sure you find the Ask the Authors corner of the digital village. You can come here, post your comments, and ask any questions you want, and maybe discuss the topics with the authors of the posters themselves. All the abstracts of each individual posters can be downloaded and found on the online abstract conference book, which is a supplement of the clinical oral implant research. And obviously all the abstracts can be downloaded via the EAO app. The Digital Village is part of the EAO's drive to upload online the highest scientific content. In fact, after the Congress, all of these digital posters will be uploaded on the online library, as well as all the other additional information during the Congress and the live webcasts.
Now, and what is excited about this online library, something you should check out right now. We're live. It's Congress here in Madrid for 3 days. And for these 3 days, actually until Monday, so for 5 days, the online library with all this content, which is normally a member-only area, is open to anyone in the world. So you can actually get a sneak preview of the type of benefits you can get as a member there. So what you need to do is visit the EAO.org website, click around to the online library, and then create a temporary access account. And you have full access both to the recorded broadcast that we created here in the studio, but also to the abstracts, to the e-posters and all that stuff. So definitely go check it out if you're interested in that. I can see our speakers are about ready. I think they're still getting their mics on. So that allows me to ask my experts just a quick question. It was already briefly addressed on stage, but with EAO, we're trying to bridge the gap between science and clinical practice. We're going to do the clinical practice in a minute. Where are we in the world of science in regards to all these virtual workflows? Because obviously technology is going really fast. Mm-hmm. What is happening there?
Well, some interesting about science is that you always have pros and contras, and both pros and contras will come with the citations and the references that they have. We also in our university very involved to look at the digital workflow. It's actually the main topic of our university, and what we find is unfortunately a lot of science that we have is out there is not really looking at the big problem, not every step problems, and they try to, go around it a little bit. So there is the science and the digital dentistry. You have some part that can really rely on, but let's say there is not enough science to draw any conclusions today, unfortunately. Yeah. And that would be something that maybe in the near future should be happening.
Yeah. Because the evolution is so fast in these days that the moment you think of a study, you set it up, you come up with an ethical improvement. Yeah. You end up having to deal with already outdated software systems. So there's always, we're like hunting the timelines, but we will never be able to reach it since all the software updates are thrown at us in such a short time. Still, I think there's very promising outcomes that we see. For sure, they're like on 1, 2, or 3 years, but it looks very promising. I think this we have to take into consideration and point out. We also understand that the clear benchmark for understanding if something lasts is between 5, 7, and 8 years, we will not be able to show this today.
Yes, today. Yeah,
exactly. So that's a challenge for the industry. Yeah. And I guess it comes down to combining clinical experience with evidence and sharing all the experience amongst each other, and in that way advance the field. It looks like they're all ready, so let's step around. Ali, if you join me around this corner. Vincent, if you move over a bit. The first one to come up is Stefan Wolfart. Congratulations. Yes. Welcome in our studio. Thanks for being with us. Not sure why Ricardo is not joining us yet, but he's still looking for a microphone. Well, Stefan, we'll start with you. Welcome. We have quite some online questions coming in, so we'll take them one by one, but I guess I'll open the floor first to my experts, right?
No, I really enjoyed your lecture. As I mentioned before, it was really scientifically based and built up. It was really nice. Although you were like the analog guy, but you also showed that something you cannot do analog, unfortunately, maybe for you, but you have to go towards that. What I enjoyed a lot is that you really showed not only the really huge cases, but you also talked about things that you also see daily in the practice, and how you can approach these things. My question would be, what do you think about the diagnostic part of the whole thing? Because we were speaking before you guys came in that I think that's the digital workflow. What thing we can do today, pretty sure and pretty reliable, is the diagnostic part. What do you think implementing that already as an analog guy, but still implementing that in your daily practice?
And we are aware we're framing you as the analog guy, yes. Because it was clear there's a truth in the middle.
Exactly. Yeah.
No. I think that's really a very difficult thing, especially if you have toothless patients. Then the most important thing that you have to know is how big the vertical gap is which you have.
Exactly.
And this, in my eyes, you can make only with a setup.
Exactly.
And takes the setup in the mouth of the patient.
Exactly.
And let him speak. Let's see how the lip support is and everything. And I need this information, because from this information, everything else is a starting point. If I have to bridge a lot of vertical height, then it's much more difficult to get to make a fixed restoration. Mm-hmm. We can do it, but it's much more complicated.
Yeah.
And we need, in the end, at least for 1 year or half a year, long-term provisional first, and then because we're changing so much with the function, with the speaking function, and also for laughing of the patient, so that I want to check it with a provisional. And as I said, the first step is the setup, and that must be perfect. So I could not do it without a setup. Mm-hmm. However, when I have the setup, then I can go scan the setup and go further. There will be, as I already said, there are digital systems on the market like face scan. You can make a face scan when you know how. You can combine it with the intraoral scan, but it will not help you with the speaking ability of the patient and with the lip support and so on. And therefore, you need something which you put into the mouth and it's three-dimensional.
But still, you could imagine that this setup will be milled, printed, or digitally supported by the technician in the creating process.
Yeah, you can go for a face scan, construct everything, mill it, and put it into the mouth. That's also a setup.
But still, we need the analog way of having the patient understand and feeling this new outline for us.
And you can change it in the mouth, even if it's milled, and if it's not working at all, then you have to make a new one.
Exactly.
And if it's only some changes, you can do it. So it's not that I'm saying it has to be analog. It's only that I say we have to put something into this mouse.
Which is obviously not a digital thing. Although we have had some viewers commenting about augmented reality, but you're definitely saying that's not something we're going to do.
Yeah, augmented reality is very nice, and there are companies also on the digital markets which show you the setup. And you look into the iPad, and you see yourself. You can change your position. You can smile, and you see it. That's possible, I think, but it's not reality in the moment.
Exactly. So it's not sufficient for you as a clinical practitioner.
Yeah, it's sufficient for me at the university, because we can try it. We can we can take lots of hours to realize it for one patient, but it's nothing you can do with 10 or 20 patients in your daily office, especially not if you are restoring all of the teeth. Yeah.
Now, can I bridge to an online question?
Sure, of course.
Just to reward them. We had Sarah Renfield already during your talk, where you clearly in the matrix said, for a full arch restoration, I always go analog. And she then obviously asked, so when do you think it will be possible to perform full arch restoration with a fully digital workflow? Where do you see that coming?
The problem at the moment is that these, for example, these full arch restoration, which are out of zirconium, we have no clinical data. For that reason, I say, okay, you can do it in your office, but you have no data on that. If we have data on that, then this whole thing is changing, because then we can make the whole arch. We can make it out of zirconia. We can stain it, and it's really looking nicely. But first, we have to see if this is really cleanable, if it's stable over the time, if the staining is stable over the time, and all of this. I want to have studies on this before I'm on the stage and tell 5,000 people that you can.
That this is possible. Yeah, very clear.
That's my clear statement on that. Yeah. So for me, in the moment, I have to use metal ceramic in these cases. And when I use metal ceramic, I have to use veneering systems and so on. And so I'm on an analog workflow.
Yeah. Clear. By the way, I hear Ricardo, are you ready? Just join us, walk up, come in. Oh, you still don't have the microphone. Okay, I just heard that you were about ready. He'll join us in a minute. Okay. Let me see if I have.
Should we switch my microphone?
No. Stay. That's great. I have another question. It's related to this. What type of prosthesis is better for rehabilitating the full arch? Do we need to consider maxilla and mandible separately, or can the same be done for the both arches?
So can you repeat it? I haven't get it.
Help me here.
Should you have PFM
Which one is
in
it?
the upper and lower?
This one.
What type of prosthesis is better for rehabilitation?
Like a wraparound with composite
Consider maxilla and mandible separately.
PFM or zirconia.
Okay, so I think what the gentleman actually tried to say is, do you see when you're treating like full mouth, do you treat mandible and maxilla separately, or you have to see it as a full arch? I'm
always treating both together.
Yeah.
Because you could not see only one arch. So it's you want to have a perfect occlusion in the end. You want to have the occlusion line on the right height and so on. And therefore, I always do it in one together. However, as I told you before, I will test it. I will test it with a long-term provisional, so that
good point.
If the patient is not able to chew with it, speak with it, clean it, then I can change it. I have not made it finally. So that's the reason.
Money.
Yeah. That's the reason why I go for provisional. And as I showed you, I use a wax rim for the relationship record, so that I can be very sure that everything is on the right height.
Mm-hmm. And for the final prosthesis, you would differentiate between the upper and lower jaw to have a PFM in the upper and something else in the lower jaw, or you would really bring up the same?
If I go for...
In the meantime, Ricardo is going
Ricardo
Okay, well, welcome. Glad you were able to join us as well, and congratulations on your presentation. Yeah, we're in the middle of taking audience questions and our experts as well. Make yourself comfortable with the mic.
Singing a song.
Yeah.
Oh, you don't have to sing, unless we get a lot of hearts on the live stream. No, let's not do that.
Is it on?
Yes, we can hear you very clear. All right, guys. Ricardo with us as well.
So Ricardo, also congratulations for a very nice lecture. I enjoyed your cases. One thing is really was interesting for me is maybe cultural thing, but here at least in Netherlands where I'm working, we are really afraid to place those really big constructions. When you have a really big loss of vertical height, we're afraid to do the fixed restoration. So most of the time, let's say 9 out of the 10, we go for a removable restoration.
Correct.
From the beginning, because it's very difficult. These patients, as you showed, they are not really, they don't have the culture of cleaning. They're not really good cleaners. Otherwise, they don't end up these places, of course. And it makes it first very difficult to clean these restorations. Secondly, I think they are very, very technical sensitive to do that. And I think you can achieve the same kind of aesthetics and function when you have removable solutions? Is it something that you guys, is a cultural thing? Is like South American, or is just like your way of treating these patients?
First of all, I don't think it's cultural. Okay. And of course, I would agree 100% that aesthetics have nothing to do. It's not a factor. You can accomplish exactly the same aesthetics with a removable, with a fixed, metal ceramics, with zirconia. At the end of the day, I mean, aesthetics it's a non-issue. What it may be an issue is, as you pointed out, cleansability. Mm-hmm. And so basically what we do is we do a trial period and we see how patients respond. And the recall program that we have with these patients is to have them back and see how they're responding with hygiene. When you deliver a fixed type of prosthesis, you could always go back to a removable if and when you find that, think about this for a second. Even if they were able to clean at some point in time, these restorations theoretically should be there for many, many years. Mm-hmm. There's going to come a point in time in which the patient will not be as dexterous to be able to clean. Exactly. And so that's when you can easily transition him into removable prosthesis, for sure. Mm-hmm. So that's why I said these things are not forever. Mm-hmm. I mean, we're providing solutions that in the minds of many patients, fixed would be the right way to go. Our parameter to define whether to go to fixed or removable is more of a lip support issue.
Yes. Mm-hmm.
If we're creating a shelf, a flange that is non-cleansable, then it's almost suicidal to do something fixed.
Okay,
right?
Good point. Yeah.
But when we have the right lip support and the patient has proven to be able to clean, then we have no problem going with fixed. Mm-hmm. But for sure, removal is an option. It's a great option.
Mm-hmm. Mm-hmm. Okay. What do you think about that? What's the German kind of? Is it the same?
I can agree fully with both of you.
Yeah.
It's also in Germany. It's a way that we have much more removable prostheses, mm-hmm. and they are removable for the patients there, but they are fixed in the mouth, and that's something totally different. It's not like a covered prosthesis which is moving in the mouth. So that if you explain this to a patient, then he's also more convinced to say, okay, I understand this, mm-hmm. and we will do it like this. And if we have some problems, if we have free palate, mm-hmm. and so we have no problems with mm-hmm. convincing the patient in this way. And as you said, the most important thing is if I have too much vertical height loss, if I have too much bone on the labial side lost, then it's much better to go with a removable partial denture.
Yeah, exactly.
If I'm doing the fixed partial denture only, or the full arch only with patients who came to mouth and say, no, I don't want to have something which I have to take out, which I can't take out of my mouth.
Yeah.
Then I'm thinking about it.
Yeah, yeah.
If moving on in the topic, not to your conclusion, but in a way, yes, if we break it down to the general practitioner out there, the complex cases you showed, this is like on the edge of our chances, what the industry allows us, what the software tools allows us today. But if, let's say, I want to start off tomorrow in my own office with my own kind of tools that I have available, what can I do? Single crown, 3-unit bridge, is the full arch possible for me in a digital environment like you showed it? Or where is what would you advise a general practitioner with its team?
Where to start?
Where to start? Is it just a single crown really where we can go complete monolithic?
Again, as I try to say at the end of the lecture, I see this as a tool, okay? It's a part of the armamentarium. It's not like now I'm going fully digital dentistry. So with that in mind, you pick and choose which part of the process you utilize the digital part. Now, if you want to go full digital, of course, the way to go to start, and I think you were very clear with that, posterior single tooth dentistry is very straightforward.
Yeah, and that is by now available or possible for everyone.
For sure.
But the important point is that before you are asking this question, you have to sit together with your team, with your dental technician, and ask yourself, how should my workflow be? Mm-hmm. So there are very important questions. For example, do I accept a powder, for example, for intraoral scanning? Do I want to have the restoration in-house in my in-lab? Do I want to have a closed system or open system? Do I want to work with implants or only with crowns? Do I want to have small restoration, big restoration? That you have to ask you. Then you have to talk to your dental technician. What for possibilities he has in his office? Where are the connections between those? And if you have put all of these things together, then you can decide for one system which will cover most of the problems or the points you want to make. If you have chosen the right system, then you have to go for a long way. You have to go for school, for teaching again, and for
Education. Training.
For training, you have to go for very good training, and then in the end you start with small cases, as you said, and then you go further.
Oh, but this is perfect because this is what we're looking for here in the studio, right? From the really big rockstar presentation we saw to the baby steps, like where do we start and what does it take? So I think this is a good step-by-step guide. Something we also discussed backstage when we were listening to you is we talk a lot about the benefits for the professionals. Let me take the position of a patient. What do I notice as a patient from the fact that you will start to work digitally? What are my benefits?
Oh, I think it's an immediate and it's a phenomenal benefit. The patient, I mean, when you have the ability to offer a restoration, the same visit, I mean, and the patient sees the scanner and the patient sees your milling unit in office, I mean, it's huge. I mean, you were discussing the fact of having an open system or having an in-house lab. I mean, depending on the type of restoration, if we have the ability to provide these type of services to patients that work, in the chaotic city, and would much rather have a restoration delivered day one. I mean, I think right there you have a huge opportunity.
So you're speeding up a big part of the initial process.
For sure.
Any other?
Yeah, if you're working in house, then that means you make your preparation, you make the scan, and you deliver the crown on the same day. So that's something which is really interesting, I think. But for myself and for my patient, I will use it only for the
posterior.
Posterior.
For sure, me too.
Because this is not as nice that I want to give it to my patient in the visible area. So in the aesthetic zone. So therefore, I would say there is an indication, and there is something where you can really do something very good for the patient. And I want to be also a little bit critic with this, because every patient is very impressed if you go into the mouth with a scanner and you show them on a screen afterwards. Look, you can move it, you can go into it, and here you see the margin and everything.
Yeah.
And
next step is the virtual reality glasses.
You have it already.
Yeah.
So every patient is very impressed, but that has nothing to do with the final result.
Exactly.
Okay.
That's very.
So that's a warning here to us. So don't get hung up on the fancy tools.
No, but I think
you can impress your patient with so many things, but it's not. You can do it conventionally, and in the end, the restoration which is in the mouth, that counts. That's not, as you said, it's a tool, and you can use different tools. And the digital tool has some advantages, as you said. Deliver on one day in the posterior. Make scanning of a situation in the mouth during surgery without contact, and a lot of other things.
Yeah, exactly. I'm going to give you the word. Just a shout out to Tarek Al-Yabai, who has two questions. I see them coming. I'll ask him. But I'll first go to a question of one of our very loyal viewers. She was with us from Asia yesterday already. And again, Naomi Liao, thanks. Because it's very related to this topic of patient communication that you're just touching on. And it's about the financial part. And she asked, at which stage do you actually discuss the financial part of how much the treatment will cost after the patient agrees to your treatment plan? So where in this phase, after you've wowed them with the tools, where do you talk about the costing?
The patient cannot agree to any treatment plan without a cost.
Exactly. So it's right at the start. But I guess you also need to do some of this in order to...
views about that.
Yeah, go ahead.
No, she should stop.
No, I mean, discussing the finances with patients is something that dentists are not trained to do.
Mm-hmm.
And I think it's a fundamental issue that needs to be addressed. For many years, I had a lot of issues with that. And so this is a discussion that perhaps we shouldn't have, but somebody in our office should have. But this is something that has to be very transparent initially, because there may be financial differences if we choose one route of treatment versus the other.
Yeah.
And so, again, if you're doing a removable prosthesis or you're doing a fixed type of prosthesis, I mean, the laboratory bill is totally different. You as a technician know it very well. And so these are things that need to be discussed with patients. So when you say, first they accept treatment and then they go pay, it doesn't work that way. Patients, it's like when you're building a house or when you're buying a jacket, the first thing you do is you look at the price tag, right?
Yeah. First, it needs to look nice, of course.
And it should fit. But just maybe to add a little bit, the tweak to the question is like, do you add anything beforehand to visualize for your patient? Any kind of, let's say, tools to help to come to the decision?
I mean, I don't know how you do it, but we, of course, an image or a picture says 1,000 words. And dentists tend to be dental speakers or lecturers to patients. We give them too much information and they don't understand. So the visual will allow them to see. So typically what we have is large screens in our operatories with animations, but also with actual pictures of treatments that we've done similar to what they request. And so basically we can walk them through procedures, befores and afters, and that way they get a much better sense of what therapy entails. We go through a Q&A period in which we are as thorough as possible with what it entails. There's something in marketing called the buyer's journey. Okay, I don't know if you heard about it, but there's 3 fundamental stops. It's the awareness stage, the consideration of solutions stage, and the decision stage. So we walk that patient through such buyer's journey. We make them aware of what their problem is, and they may be somewhat aware, but we increase their awareness. And until we're done making them aware, we're going to move to the next stage, which is consideration of solutions, whether removable, whether fixed, whether full coverage, partial coverage, whatever it is. Then we talk about the implications of one solution versus the other. And ultimately then, we let the patient decide. So it's a very linear, smooth process.
And basically then if we bring it back to the dentist who might be watching, there's quite some investment going on into this phase, which is maybe not directly billable, but it's more an investment into tooling for your communication with the patients. Is that correct?
But I want to add something. For me, it's very important that the first step is without costs. So if I first I want to tell the patient what is the best possibility from a medical point of view, and that has nothing to do with cost at the beginning. And it's also my duty to do that, because a patient could decide only if you know all the alternatives. If you don't tell him 2 alternatives because you say, okay, that he has not enough money or something, that's something you never are allowed to do, because then he could not make his own decision, because he has no ideas about all the possibilities. So the first step is always without money. And as you said, if it goes to the decision, then the money comes automatically in play. The patient asks, okay, when I would prefer something like this, but how much will it be? And then in the end, they get a plan, and there's completely written how much it is in the end. And if you, for example, if you're living in Germany, you have assurance for that, then they have to give it to the assurance company, and they will totally cover different amount of money of this. So not before this step, the patient knows exactly what he has to pay afterwards.
All right. I would like to go back. Question for both to the question you raised, because what you said, giving a patient the immediate restoration, that would be a benefit. But as you said, and you agreed, that it cannot be done every time, because it depends on the case. And what you showed about, I can show the tooth and everything, it's like more, I find it more marketing than benefit. So I'm asking the question again. What do you both think that digital dentistry or digital workflow would be benefit, but not a marketing tool? I understand it's a big marketing tool and it's really nice to explain to patients. But what would be real benefit, as a patient? What do you think about that?
Okay, for me, it's if you make an impression, then it's really different for the patient if he has for 10 minutes something into the mouth. which doesn't smell, taste very nicely. And on the other hand, you can go with a scanner in the mouth. So for some people, that's nicer. Other people say, okay, this other thing which you're going into mouth, it's also not very comfortable. So it's up to the patient if this is really helping the patient. Then, as I told you, during surgery, if you make something, when you can deliver something very, very fast, then you have no provisional period. So as a pulp is covered immediately after preparation again, definitely without a provisional cement. And so that is something which can help the tooth vitality, for example. So I think there are different advantages.
But can you say to the patient, what I am delivered to you digitally would be on a better quality, longer lasting restoration than the one because that would be the benefit, right?
I never would say something like this.
And you?
No.
I think the question is a bit ambiguous.
Well, that's what happens here in the speaker's corner.
In all fairness, I mean, if you were to think what's the best for the patient, I was trained as a prosthodontist at the University of Washington, and I was trained doing gold restorations. I think gold restorations are the best. Will patients accept a gold inlay and onlay? In fairness, 95% of my patients will not accept it. Do I think they're wrong?
I have also one.
And I have gold in my mouth, and I show that to them. Now, I still haven't done a single gold restoration digitally.
Yeah.
Right?
But you could.
For sure. Exactly. But the bottom line is, again, communicating with patients the benefit of getting one restoration versus the other. I mean, and you can play both ends. If you have digital capabilities in your office, I mean, you can prep a tooth, you can scan it, look at the scan prep, and then improve it until it's perfect.
Yeah,
so that's a good benefit.
That's
what I want to hear.
So at the end of the day, this is not a white or black decision. It's about embracing technology and doing the best you can to see what technology can bring to you. This is not about, oh no, I'm better because I'm an analog technician or I'm better because, listen, in all fairness, I was trained in the laboratory as a prosthodontist. I had to do every single step of my full mouth reconstructions. So I burned my fingers, I baked ceramics, I did post-ceramic soldering. I mean, I know all these steps. I am highly respectful of what technicians do. And so, again, it's not about cutting corners because we have now a better approach, but we have a more manageable approach.
Exactly.
And so if we embrace technology, I think ultimately it's much faster to get to a much solid point down the road. Now, patients need to hear this and the patients need to understand it as well.
Yeah.
Plus, I think there is the factor of the restorative material that you nicely showed. That, I mean, there we see clear evidence that if you eliminate the veneering ceramic or the veneering composite or whatever we veneer, we will have a better longevity of our reconstruction because we eliminate the risk of technical failures, or at least of a huge amount of the technical failures. And to do this, we need to have the digital tools, correct? So there's a clear benefit.
And that's for me also very important that the most important part when we discuss about digital is the lab, not the dentist.
True.
Because in the lab, nearly everything is digital. And and there it will stay digital. For us, it's only the impression what we are talking about.
Yeah.
And the planning.
And the planning.
I think the planning is the fundamental.
And the relationship.
And the relationship. Well, that's actually quite a lot too. Now, we're nearing the end of this speaker's debrief, but I want to go back to one final online viewer question. But I notice it's kind of out there in a different area, but it's actually addressed to all four of you. And it's from Tariq Alabai. He's in the Middle East, as far as I can discover. And he's asking, which is better? Extraction and immediate placement of implants, or extraction and wait healing and later place the implant? And how long is the healing after extraction? It's quite technical.
For this session, or was it?
I don't know, but I just want to take it because it's live and you guys probably have an opinion on that. So I want to reward him for being interactive with us. So
it's a very difficult question to answer because it depends on the case.
Okay.
And, you cannot.
All the great questions are answered with "it depends."
Yes. Of course.
It depends. That's dentistry, right? That's dentistry.
Yeah.
It depends on so many factors. I mean, it depends on the situation of the moment that you are extracting the tooth, the site that you are placing the implants. I mean, the actual stability of implant after placement. There are a lot of guidelines to do, and also the preference of the surgeon. I mean, there are also people that they do not like to do immediate restoration at all, and they have their own reasons. So it depends on so many factors that I think I cannot.
This is unanswerable.
I think I cannot. We cannot
can
answer.
Can you identify in which scenarios immediate is most suitable or practical?
Well, there are guidelines. I mean, there are consensus meetings, and there are some guidelines to help you a little bit to go to the direction. I don't think that there is any clear answer to that. It depends again on the case to case, but there are guidelines that you can use.
The best answer for this question is guidelines.
Exactly.
We should go to the internet and look for guidelines.
Yeah.
This is a beautiful. No, this is a
it's
beautiful
really a beautiful answer because it's not possible to answer this question in a setting like this.
Yeah. Both EAO and ITI, they have really guidelines very, very clearly on that.
And it makes me happy because that's what we've been advocating here all the time. So, Tarek, first of all, if you're uncertain about this topic, it's comforting maybe that this is a situation of it depends, and you really have to dive into it. And the guidelines that is being referred to are to be found in EAO's online library. And that's actually what we're producing all this content for. So that's why I was so happy with your cue. If you're curious about the online library, it's normally a members-only benefit. But during Congress and a few days after, during the entire weekend, it's open to everyone. So Tarek, go to the EAO.org website, click on online library, and you'll be able to get a temporary access and browse and dive deeper into it. So thank you very much for that. With that, gentlemen, I want to thank you a lot for stepping off stage and be brave here and be questioned by our experts. A final big thank you to my team here in the studio. Thank you very much. A big thank you to the team behind the scenes today. I'm looking forward to see you back tomorrow.